Yeah,
Please go
very
ahead.
good morning. Thank you. Very good morning, every participant today. This Sunday morning is quite vibrant, and from MRA, on behalf of my team, My Rehab Academy, I welcome you all for today's event. I welcome Dr. Arunachalam Ramachandran, who has taken pen for delivering today's webinar as well as the kind of content or scientific content on Sunday morning. My Rehab Academy, as you know, it's a platform which connects physiotherapy students, professional, clinician, and academician to the best of instructors across the globe for upgrading their skills in academics as well as in clinicals. And now I can say even in the research part, because we are coming in such a form that we will be able to assist people in the research also. No matter you are the student, you are academician, you are clinician, we are there everywhere for you. My Rehab Academy is one of the brand which has got the best award in education sector for rehab sector. Sorry, for rehab education. 3 months before by one of the leading agency called Brand Molds. You would have seen our presence on the social media. Our core member has made it very specific and it has made it in such a way that it can have reach everywhere. Our membership program is open and that is having some benefit like you can access unlimited time our library, you can meet our instructor regularly, you can actually have like audio as well as video study materials on demand, and these all things are at zero membership fee. That offer is there till that offer is there till 31st of this month. And then kind of discount, the most precious part I wanted to say at last so that you could remember, up to 30% discounts across the physical as well as the digital event for whole life till the membership card is active. You will be able to get for complete India, for complete zone of India, right from uh, Kashmir to down the south. So from north to east, south to west, everywhere, wherever our physical events also happen, you'll be able to get discount as well as the digital events. Of course, you'll be able to get discounts. So these discounts will be applicable only and only for the MRA Life members. And this is not all. Many of our events, at least 2 events on an average every month, we are keeping that will be completely free for our MRA Life member. That won't be free for others now anymore. So those who have been our member, I welcome. Those who are not our member, you can just join with one link. It's very simple. Once you join the link, you'll get a form. That form, it will take hardly 2 minutes to fill up. Once you fill up and submit, your membership card will be ready within 2 minutes. This is my promise. And if that is delayed, that will be because of the internet problem, not our problem. So before starting today's event, I would like to welcome once again Dr. Arunachalam Ramachandran. I think sir had joined and he'll be joining any minute. Yeah,
I'm there.
yeah, yes, sir has joined. Yes, yeah, he is principal of Madhav University, Rajasthan. Sir has extensive experience in neurological rehabilitation, and I welcome you, sir, on behalf of my whole team. Your presence in academics as well as in clinicians have been definitely remarkable. It's not very simple. Your profile, if I start detailing, I think it will take another 20 to 25 minutes for me to detail. You have been a peer reviewer for many of the journals, many of the prestigious journals from Europe as well as from the USA. And recently, you have been very active member for supporting the research part. And I heard that uh, two of your person whom you actually guided have completed recently PhD also. So that is something a great achievement from your side, and we are very happy as well as we feel very proud to have you on our board as scientific coordinator. So welcome you on the board. Kindly you can start your it's over to you. You can start your content.
Yeah. Good afternoon. Good morning to everyone. Thank you, Dr. Saurav. It's always pleasure listening to you. And nowadays, Sundays have become like Mondays for me. Friday nights have become Saturday nights for me, and all Sundays have been always busy nowadays. And today it is a pleasant Sunday in Chennai. We have good rain, and we are all very pleasant. And it's great to see my Rehab Academy team. My thanks to Dr. Kalimullah, who dragged me into this team and who is maintaining me. And I thank Dr. Diwakar. I also thank Dr. Sumanjeet, CEO of My Rehab Academy. So this is a team where there is a lot of energy. They are constantly thinking about what to do next to the professional growth as well as for the students particularly. Their contribution is going to be immense in future. I can see a lot of aspiring ideas from them, which is going to reap rich benefits in future. With that introduction, I would like to start today's program. Uh, so, why this topic was selected? If you see, I normally believe basics are the advanced content. If only a person knows the basics, then he is considered to be a person with in-depth knowledge. Um, Unfortunately, in orthopedic assessment, if you see, you have an assessment pattern where you go about in analyzing what is the impairment. When I say impairment, I mean about the anatomical structure, maybe a dysfunction or derangement, whatever it is. But you are going to find out the anatomical structure in the orthopedic assessment. But in neurological assessment, in the clinical scenario or in the colleges or in the universities, wherever you perform the assessment, you know what is that condition. The assessment is tailor made for that condition. Am I right or not? I have seen many times people asking me, sir, I don't know stroke assessment, I don't know spinal cord assessment. So how do they know that it is a stroke patient? How do they know that it is a spinal cord injury patient? Because here the medical diagnosis and the physical diagnosis are apart. They are based upon the condition. It is a condition based assessment. It is not physical diagnosis or physical diagnosis from physical therapist. It is mostly condition oriented. Whereas if you see in the orthopedic assessment, they have come to an extent where the assessment is not condition oriented. If I say periarthritis assessment, I may not be sounding correct. In periarthritis, you are going to identify which is the particular periarticular structure that is inflamed. So they have gone so deep into the impairment level, and the physical diagnosis in orthopedic assessment is possible these days. But the physical diagnosis, as far as the neurological conditions are concerned, are mostly a formality. I think people in this group would agree with me, because what is meant by assessment? Assessment is identifying what is the ailment, identifying what are the problem list, and what are the hints for the future intervention. But when it comes to neurological condition, when a patient walks into you, you know that he is a Parkinson patient. Most of the time, he is being declared that he is Parkinsonism. And your treatments are also predetermined. And here, the assessment becomes a mere formality. But for a first visit practitioner, if a physiotherapist wants to claim that he's a first visit practitioner, he should know the differential diagnosis. He should know before anybody diagnose a condition, if the patient walks into you, without referring the patient to the neurologist or without referring the patient to elsewhere, you should know how to assess the patient. That is the main concept of differential diagnosis. I definitely know that it is not going to come in 1 or 2 days of patient assessment and clinical practice. It is going to take a lot of time for you, but the basic knowledge what you want to attain is very important. If you don't have a strong basics, you will progress with the pseudo basics. That is a pseudo knowledge what you have got, the knowledge which is not correct, which is not physiological, which is not scientific. With that knowledge, you will progress, and it will affect your clinical practice. And thereafter, whatever experience you have gained out of that particular clinical experience is going to be not that significant, because you are practicing on myths, not on science and physiology. So basics, my dear friends, anatomy and physiology of any system is very important, and that is the only thing that is called as advanced when it comes to uh, uh, biology as such. So first class, in this, I will give you a disclaimer that every time you see anything, any condition, you approach anything, there will be a lot of physiology involved in that. Without physiology, we cannot explain anything, and you cannot register anything in your brain. If you know why, when, what, where, then you'll be able to remember things in an authentic manner. Otherwise, you will remember them using mnemonics, or just remembering by means of just relating not on the basis of the physiology. So let me share my screen. Okay. Saurabhji, you're able to see my screen?
Yes, sir. Yes, sir.
Yes, sir. Nice.
So I like this picture. I am so impressed with this picture because this is a teacher's point of view. You can see all the towards the teacher, and the teacher has one more board on the back side. That's why I stole this picture for my neuro classrooms. And in this COVID scenario, classroom has become a dream. And even for teachers, not only for students, for teachers also, standing in front of the students and taking has become a real dream. Uh, so I just wanted to put this as my profile pic. Okay, now to understand about the assessment, I'm coming from the basics. Your nervous system. The nervous system can be divided into the central nervous system and the peripheral nervous system. It is located in the head, but it is the coordinating center and integrating center for every activity in the human body. And the peripheral nervous system is peripheral because it is not only anatomically based peripheral, but also it is coming far away from the nervous system, and it is just executing the activities of the central nervous system demands and commands. So the central nervous system can be divided into brain and the spinal cord. You all know that. I don't want to stretch too much into that. And the peripheral nervous system is divided into the motor nervous system and the sensory nervous system. And the motor nervous system is subsequently divided into the somatic nervous system, which controls voluntary movement and all the skeletal muscles of the body, particularly the appendicular and the peripheral musculatures. And the autonomic nervous system, which is the most ignored nervous system in the human body, particularly by the physiotherapist, controls involuntary responses, all the visual contents, visual events, and it is being divided into sympathetic and parasympathetic. So these two components of sympathetic and parasympathetic are going to be a counterpart, which are complementary to each other in controlling the smooth muscles of the human body. This is the outline sketch of the nervous system. So a lesion the nervous system, uh, or anything that is contributing to this nervous system can also be affected, particularly like the nutrition to the nervous system. Vitamin B12 deficiency is a major ailment. So our differential diagnosis is going to not only find out lesions in these parts of the nervous system, but also to the things that are contributing for the nervous system, particularly the neuromuscular junction. Until the end of the nerve from the higher centers, the nerve impulse may be passing on very smoothly, but is that impulses transmitted to the muscle? That depends on the neuromuscular junction. So this is how we are going to differentially diagnose in this coming classes. Now I want you to know some more basics. You know about neuron and the neuroglial cells. Leave out about neuron because you know neurons very well. So I'm going to neuroglial cells. So what are these cells? What are the significance of these cells? These cells are there in the brain. These cells are there in the brainstem. They're also present in good quantity in the subcortical and cortical structures. But They are not present in the spinal cord. They are not present in the peripheral nerve. So what is this going to cause? Going to be better than the brainstem. The recovery rate of brainstem is going to be better than the spinal cord. So the spinal cord and the peripheral nerve do not recover properly because they don't have neuroglial cells. This is one of the factors. So what are these neuroglial cells? These are support cells of neurons, which can help the neuron in regeneration or reorganization or distribution of the functions. So that is the role of the neuroglial cells. For example, we have four main neuroglial cells. The first one is the astrocytes, which are regulating the blood supply to a neuron. They adhere with a neuron with the blood cells, and obviously if the blood vessels are adhered to the neuron, it is going to maintain the internal ambience or the environment of the nerve cell by bringing in more nutrition and taking out the unwanted products from the neurons. And they also help in the blood brain barrier. So when I say blood brain barrier, every infection cannot reach into the uh, brain and the nervous system. Every infection of your blood cannot be transmitted to the brain because there is something called as a blood brain barrier, which is formed by some anatomical and functional components, which prevents the infection from crossing the barrier and getting the brain affected. So we all see COVID. COVID do not affect the brain because COVID cannot cross the blood-brain barrier. If you see, staphylococcus can travel strength of tuberculosis can cross the blood-brain barrier. That is when they causes the meningitis. So all these infections which are blood-borne cannot travel across the blood barrier because of the presence of the astrocyte. So next one is the microglia. They are the cells which are useful for the defense mechanism against the pathogens. Again, this is also a part of the blood-brain barrier. They also control the water content of the neurons. The ependymal cells, by the name itself, we can know this is something which is used for the lining of the brain, particularly the brain and the spinal cord. You have some lot of cavities which are fluid filled. So those fluid filled cavities can be they are lined by the ependymal cells, and they also influence the production, transport, and the absorption of the cerebrospinal fluid. Apart from that, you have oligodendrocytes, like you have Schwann cells in the peripheral nervous system. In the central nervous system, you have the oligodendrocytes. They are the one which produces the myelin sheath. The myelin sheath that is produced in the central nervous system is different from the myelin sheath that is produced in the uh, peripheral nervous system. The oligodendrocytes produces myelin sheaths which are much thicker, much extensive, and one cell of oligodendrocyte can produce more number of myelin compared to the myelin produced by the Schwann cells in the periphery. Okay, so next we are going to when I say the terminology, the nerve, when I say nerve, a group of fibers outside the central nervous system. So what we should not do is we should not say the nerve fibers passes from the right cerebral cortex to the left cerebral cortex. The nerve cells passes from the brain to the spinal cord. We should not use this word nerve because the classical definition of a nerve itself is it is out of the central nervous system. Just for your knowledge sake, but interchangeably we are using this terminology, not an issue. Next is the ganglion. What is meant by ganglion? You come across this name ganglion everywhere when you are studying. Ganglion means a collection of cell bodies. So when I say neuron, neuron has a cell body, axon and dendrites. So where are these cell bodies? They are always found in a collective manner. The nerve cells are in a collection. So if it is located outside the central nervous system, it is called as a ganglion. Okay, and if it is located inside the central nervous system, they are called as nucleus. Got it? So nucleus and ganglion. A classical example is the posterior root ganglion or the dorsal root ganglion, which is near to the spinal cord, is the one. And for the nucleus, you have a lot of examples. You have basal ganglia, nucleus, You have a nucleus for the cranial nerves, and you have nucleus for the gracilis and cuneatus, the sensory relaying of the proprioception. So nucleus is the gathering of nerve cell bodies which are located in the central nervous system. Next is the gray matter and the white matter. Gray matter means there is a lot of cell bodies located. They looks gray in color because of the matrix substance within the nerve cells. And white matter looks very white. They carry only the nerve axons, which do not have any cell bodies. They look white because of the myelin sheath, which is rich in protein, which gives a white color to the these things. So when I told you about the difference between the myelin sheath in the peripheral nervous system and the central nervous system, you can see the chaining of the oligodendrocytes, and oligodendrocyte produces myelin for multiple axons, whereas the Schwann cells produce only for one thing. And see the distance between the nodes of Ranviers of the peripheral nervous system and the central nervous system. You have nodes of Ranviers very widely away from each other. That means the saltatory conduction here of nerve impulses is going to be very fast, and there is going to be parallel processing of the information because the axons are connected parallelly. So any complex information can be easily progressed and processed through this particular type of nerve chaining, whereas here only monotonous information can be either it is inflammatory, excitatory or inhibitory. That is the only thing that is going to be transmitted through these nerves, and they are going to be much slower than the processing that happens in the central nervous system. Why? That is mainly because of the oligodendrocytes which are present. So when I said about the nervous system, you have sensory and motor. The sensory sends information, collecting the information from the sensory receptors, and it relays the information to the posterior horn cells. And for this, the information or the reaction is going to come through the efferent system. So one thing we have to understand that the human nervous system is really reactive. Any sensory input given to that, the nervous system should respond to that. It should detect that and it should respond to that. The response may be a motor response or motor silence. For example, I'm sitting in this chair. I am getting a constant sensory input from this chair, but I'm not giving any sensory output to that particular chair, motor output to that particular chair. But when the sensory input from this chair is hurting me, I'm having some pain, then I slightly adjust my chair and I sit in a different posture where it doesn't hurts me. So either my central nervous system will give response or it will not give response. Both of them are considered to be the central nervous system or the nervous system response towards the sensory input. So it is detecting it. Whenever needed, it gives response. Otherwise, it remains silent. Both of them are considered to be the response. So, my dear friends, for understanding better neurological assessment, the most basic thing is reflex arc. Reflex arc and stretch reflexes are the basic thing for which you can do a large amount of differential diagnosis. A huge amount of differential diagnosis can be done using this particular basic analysis. Fine. What is meant by a reflex arc? You all know that when a sensory information is given through the skin or through any other sensory receptors in the body, the information is carried by the sensory nerve fibers, and the information goes to the posterior root ganglion. Through that, it goes to the posterior horn cells and it goes to the anterior horn cells through the internuntial neurons. The internuntial neuron can be excitatory or inhibitory, that depends on the certain inputs which receives from the brain. And this information from the anterior horn cells goes to the motor system and the response is produced. In case if somebody is giving you painful sensory stimulus, this is going to be a strong motor output. when it is going to be a very soothing and massage type of sensory inputs, your muscles are going to relax. So this is the reflex arc. So in order to find the important centers here, important features here, what are the important features, what are all the contents which have to be intact for a proper reflex arc? You need, first of all, a receptor. Okay, the sensory receptor is the first one. Okay, one. Second is the sensory nerve fibers. You need a proper spinal integrating area because the reflex arc is controlled by the spinal cord. So you need a proper anterior horn cells numbers for the response to be produced. This is a 3. The fourth one is the motor nerve fiber should be normal. That is 4. And finally, the muscle is the effector organ, and the muscle should be normal. That is the another component. So how many? Receptor 1, sensory nerve fiber 2, the spinal integrity 3, the motor nerve 4, and the effector organ, that is the muscle, that is 6. But for testing this integrity, every time you cannot poke a patient with a pin, or you cannot give a sensory input regularly to know whether the reflex integrity is nice or not. So what you use to find out the spinal integrity in the clinical practice is your deep tendon reflex, that is called as the stretch reflex. So when I say stretch reflex, you should know something about a muscle spindle. So the muscle spindle is nothing but a small chocolate like substance which is there in the muscle. When I say chocolate, because whenever I see a muscle spindle diagram, I always remember about a chocolate, a small candy wrapped up by paper. So this substance are connected parallelly to the extrafusal muscle fibers. What are extrafusal muscle fibers? They are nothing but the long muscle fibers which are running in a muscle, because you know that muscles are made up of a lot of muscle myofibrils, and myofibrils combine together to form the muscle fibers. You can see the actin myosins here in this muscle fibers. Here you can see the actin and myosin dark zones and the bright zones. So this is the extrafusal muscle fibers, and you can see that the muscle spindles are connected parallel to them. Okay, so what is the role of this muscle spindle? The muscle spindle has some sensory nerve fibers which are surrounding the there. Uh, this is called as nuclear bag fibers, and you have nuclear chain fibers. So there are nerve fibers which are surrounding these sensory receptors, and when the sensory receptors, which are very sensitive, get stimulated, this information passes on through this particular sensory nerve fibers. Again, this nerve fiber information goes to the posterior horn cells. Okay, so when they can be stimulated, the muscles can be stimulated only when they are stretched. When I say they are stretched, when I say stretching, a mild stretch, even a mildest of the mild stretch, can stimulate the muscle spindle. So when the muscle is contracting, these muscle spindles will not get stimulated. Can you see this? The firing rate of the muscle spindles when the muscle is contracting is less. This is the normal resting state. But when the muscle is getting stretched, then you can see that the muscle spindles are firing much faster than the others. So now, when I tap a knee hammer onto a patient, what happens? The muscle spindles first get stimulated because they are very sensitive. So they get stimulated because when I tap, there is a very mild stretch that is happening in the muscles, the tendon, and that is pronounced in the muscle spindle. So there is an upper information. You see the blue color line, which goes all the way up, and it goes relays to the posterior horn cells. From the posterior horn cells, two alpha motor neurons are stimulated. What are they? Alpha motor neuron for the agonist, alpha motor neuron for the antagonist. But how they are stimulated? One is excitatory, the other is inhibitory. The one on the red is excitatory. Okay, and another one on the lavender color is the inhibitory. The alpha motor neurons of the agonist are going to be facilitated, and the alpha motor neuron of the antagonist is going to be inhibited. This is called as reciprocal inhibition. When only this muscle, hamstring, is relaxing, the quadriceps can contract and produce a small oscillation of the feet. If you imagine, if the antagonist is not being suppressed or antagonist is not being inhibited, both these muscles will contract and there won't be any activity. So this is called as the reciprocal inhibition. So this is nothing but stretch reflex. When you tap your knee hammer on the tendon of the muscle, you get a small oscillatory response in the leg, or you can see a palpable or visible contraction of the quadriceps muscle. This is called as the stretch reflex. Am I right? So this mechanism is also influenced by some central nervous system, the influenced by the brain, basal ganglia, and the reticular activating system, which we will see later. When I'm telling you about the spasticity, we'll know about this. So now, as of you just remember whatever I have taught you, that the stretch reflex. Now there is one more anatomical structure called as the Golgi tendon organ. What is a Golgi tendon organ? There is a difference between the muscle spindle and the Golgi tendon organ. Where I said that the muscle spindles are connected parallel to the muscle fibers. The Golgi tendon organs are connected in series with the muscle fibers. So in electronics also, you know the difference between coils connected in parallel and coil connected in series. Which conducts very fast? Coils conducted in parallel conducts faster than the coils which are conducted in series, because they undergo a lot of resistance. Likewise, any sensory input from the muscle can influence the muscle spindle more compared to the Golgi tendon organ, because you can see that the Golgi tendon organs are not attached parallel to the muscle fibers, but they are attached series. When I say parallel, these are the extrafusal muscle fibers, and this is the Golgi tendon organ here. So they are connected parallel. So when I say series, this is the extrafusal muscle fiber, and the Golgi tendon organ is connected here. So that is meant by series. So tell me, when there is a small muscle stretch, which can get stimulated first, this muscle spindle or the Golgi tendon organ? It is the muscle spindle, because it can experience it much earlier than the Golgi tendon organ, which is connected in series. So what is the role of the Golgi tendon organ? When the Golgi tendon organ is stimulated, the muscle goes for a relaxation. Whereas we saw that the muscle spindle, when it gets stimulated, it goes for a contraction of the muscle, extrafusal muscle fibers. So just give me a second, please. Sorry. Saurabji, you're online?
Sir, tell me, sir. Yes, sir.
Yeah, yeah. I was audible until Golgi tendon organ.
Yes, yes, sir. 100%.
Yeah. Okay, thank you. So this Golgi tendon organ is a protective mechanism in the human body which prevents the muscle from overstretching. When you are stretching a muscle beyond certain limit, what happens is this muscle will not contract. It leaves its contraction and it becomes completely relaxed. So this is a gift which is God's given for us to prevent injury for the muscle fibers. So one thing you have to remember is when a muscle spindle extrafusal muscle fibers goes for a contraction, whereas an Golgi tendon organ, when it is stimulated, the muscle goes for a relaxation. Next, very important things we have to know about is the tracts. You have ascending tracts and descending tracts. So please don't mistake me that I am taking a lot of time for the anatomy and physiology, because differential diagnosis is all about spotting the anatomical structures which are not functioning. So without knowing the anatomy and physiology and the function of all these things, it is going to be tough for you to understand the differential diagnosis. You cannot understand. I can directly tell you about the um, differential diagnosis. That's why when we were discussing about this class, we thought we should give more number of hours, that is around 4 to 5 hours for this, because definitely 1.5 hours will go in the anatomy of nervous system. Very important anatomy. I'm not telling you everything and boring you, just very important things I'm going to tell you. In that way, the tracks are very important. The ascending tracks and the descending tracks are very important structures, because the sensory information is carried through the ascending tracks. So when it comes to ascending tracks, you might be knowing about the first order neuron, second order neuron, and third order neuron. Very classically, you should know that we don't use this third order, first order, second order in motor nervous system. That is the descending descending tracks. We will not use this word. Likewise, in descending tracks, we use this word called upper motor neuron and lower motor neuron, but we don't use that in case of ascending tracks, because there is no motor neurons involved here, because it is a purely a sensory tract. It carries information from the periphery and to the center. So when I say tract, that means collection of nerve fibers which are running up and down in the spinal cord. As long as they are in the spinal cord, they are called as tracts. You should not say that there is a tract in the brain. It is only pertaining to the spinal cord. Uh, Next is the spinothalamic tract. What is the function of the spinothalamic tract? And you have to say how it crosses over. It carries information about pain, touch, temperature, and mild pressure and crude pressure. All these superficial sensations are carried by the receptors, and it comes to the posterior horn cells. From the posterior horn cells, you should know that it crosses to the opposite side at the spinal cord level itself to the white column. That is the white column of the lateral spinothalamic tract or the anterior spinothalamic tract. It enters into the gray column and crosses to the opposite, and it occupies the white column, because the nerve cell body is going to be here, and the cell body gives axon, and the collection of axons are obviously going to be in the white matter. That is what we have seen previously, that what is the difference between a gray matter and a white matter. So which is the first order neuron here? The first order neuron starts from the receptors and goes and gets synapsed with the second order neuron in the posterior horn cells. Okay, where is the cell body of the first order neuron? It is located in the posterior root ganglion. We have seen already that ganglion means collection of cell bodies outside the central nervous system. So here is the ganglion, and the nerve synapses with the second order neuron in the posterior horn cells. Got it? So this information from here on is going to be sent upwards on the opposite side. It is going to occupy the opposite side, and it goes upwards. And what happens? It goes up to the brain stem. In the brain stem, it crosses the medulla, pons, and the midbrain, and it is going to relay in the thalamus. In the thalamus, the second order neuron will end, and the third order neuron will arise, and it will go to the sensory cortex in the brain. Got it? So three order neurons are there. The first order up to the posterior horn cells, the second order up to the nucleus in the thalamus, the third order from the thalamus to the cerebral cortex, sensory area of the cerebral cortex. So very importantly, you have to remember the spinal crossing of the spinal thalamic tract. The spinal thalamic tract crosses at the level of spinal cord itself. So this is going to be important for your differential diagnosis. The second thing is the posterior column, or the cuneatus and gracilis, tract of cuneatus and gracilis. So they carry the deep sensation, namely the proprioception and kinesthesia or vibration. Again, there are receptors for separate receptors for all these things. Particularly, they are located in and around the articular region, deep inside the capsule or the ligaments, and they carry the information from there. Again, goes to the posterior root ganglion and then comes to the posterior horn cells. Relay the information here. The nucleus. Now here, the first order neuron ends and the second order neuron starts and goes up to the medulla. In the medulla, you have here you have to note one thing, that this does not crosses. As soon as it enters into the gray column of the posterior horn cells, it goes to the white column on the same side and it ascends upwards on the same side. It does not crosses. It goes to the medulla, particularly the lower medulla. In the medulla, it has the nucleus of gracilis and nucleus cuneatus. Here is the second order neuron located. From here, the informations are taken to the thalamus. The second order neuron, from the thalamus, the information, the third order neuron carries the information to the cerebral cortex. So this portion of the tract traveling in the brainstem is called as lemniscus, medial lemniscus. Medial lemniscus is a combination of the nucleus, the fibers from the gracilis and the cuneatus, but the name differs. It is called as a medial lemniscus here. Okay, when I say this thing, you have to know where are the first order neuron and where are the second order neuron, third order neuron for this particular tract. Okay, here the first order neuron is from the receptors to up to the brainstem, and from the medulla the second order neuron starts and goes to the thalamus, and the third order neuron from the thalamus to the cerebral cortex. Got it? So next is the spinocerebellar tract, much often ignored tract. They send information from the deep sensation received, and it sends information to the cerebellum directly. So why this tract? What is the function of this tract? This tract is going to compare the intended movement with actually happening movement. The brain has instructed you to draw something. The brain perceives that drawing should be in this manner, but how you actually draw, the drawing is going to be compared whether the movements of your hand are as expected that of the motor program or motor planning, and whether it is executed in the same manner or there is any difference. This comparison is going to be done by the cerebellum. For that, what is the tract that is responsible? The spinocerebellar tract. Now, having a look at the descending tract. So descending tract has an, to remember that, and the descending tracts are divided into two broad. This class is all about these two categories, the pyramidal system and the extrapyramidal system. If you don't understand what is pyramidal, what is the role of pyramidal, you cannot understand the neurology and the function of the nervous system. The pyramidal system and the extrapyramidal system are so vital that they are going to be very important for the differential diagnosis also. So now I'm saying about the pyramidal system. You have two tracks in pyramidal system. One is the corticospinal tract. That is what is seen here. The corticospinal tract is otherwise called as pyramidal tract very commonly because they arise from the pyramidal cells of the cerebral cortex. Cerebral cortex has granular layer, molecular layer, pyramidal layer, Okay, so like that, in the pyramidal, internal and external pyramidal layers, you have some cells called as the bird cells, BERTZ, birds cells, or otherwise called as pyramidal cells or giant cells, because they are the largest cells of the cerebral cortex. So these cells gives rise for these tracts, and the tract after getting arise goes down as corona radiata and gets condensed in an area called as internal capsule. By the name capsule itself, you can understand that you know that medically important substances are kept inside a capsule, and it is given, you know, how densely they'll be packed inside the capsule. Likewise, this capsule in the central nervous system incorporates all the sensory and the motor nerve fibers very closely arranged here. Okay, so after entering into the internal capsule, it comes down to the midbrain. Okay, in the midbrain, and then it passes to the pons and then to the medulla, and in the medulla it crosses to the opposite side. Remember, not 100% of the nerve fibers crosses to the 100% of the pyramidal system crosses to the opposite side. Only 80 to 80, only 85 to 90% of them crosses to the opposite side. Remaining 10 to 15% remains on the same side. The one that crosses to the opposite side are called as lateral corticospinal tract. The one that remains on the same side is called as the anterior corticospinal tract. So that is why we say the left side of the brain controls the right side of the part. And the same side, if there is a CVA on the left side, it affects the upper limb and lower limb on the opposite side, and also have a small residual impairment on the same side, simply because there is a 15 to 10% contribution of the ipsilateral corticospinal tract onto the trunk muscles. This anterior anterior corticospinal tract will influence the trunk musculature. Okay, got it. So this is the anatomy of the corticospinal tract. So what is the role of this corticospinal tract? The corticospinal tract is involved in fine movements of the body. It is going to bring about movements of the body, and it is going to predominantly influence the flexors of the body. When I say predominantly influence, that means it also influences the extensors of the body, but its influence is distributed in such a manner that it predominantly influences the flexors of the body. Unlike this means that the extrapyramidal predominantly the extensors of the body. So the balance between the pyramidal tract and the extrapyramidal tract is very essential for the diagram about the distribution of the lumbar and the thoracic region. You can see this color coding. You see, once the pyramidal tract comes to the midbrain, which is more medial, the cervical is more medial, the thoracic later on, and the lumbar is in the outer side. That means when the spinal cord is when the tract is traveling down, the outermost, that is lateralmost part pertaining to the lumbosacral region, and the middlemost portion is called is pertaining to the cervical region. The significance of this I will let you know later, but you just remember that in the motor system, the sir, please repeat. Video and voice is breaking. Lalit Yadav, which part you want me to repeat? Mr. Lalit Yadav? You can just type. Fine. Let me know later. I'll repeat that, not an issue. So one thing you have to remember is in mass as it is in motor system, the fibers which are carrying information from the brain towards the spinal cervical region are placed more medially, and which are the one which is carrying information to the lumbar sacral region are more laterally. Now the second tract is otherwise called as the second tract is called as the bulbar tract. Um, this corticobulbar tract is a very important tract for the differential diagnosis of the nervous system. So if you guys want a break, we can break here, and we can start after 5 minutes. Is that okay, Saurabh?
Yes, sir, please.
Okay, so before you go for a break, I would like to play them a video. Um, yeah, you're able to see my video?
Yes.
Hello and welcome to Neuro Classroom. Today we are going to continue with the basics what we have seen in the last class. It was about the upper motor neuron lesion and the lower motor neuron lesion. We saw about the corticospinal tract, which is one of the pyramidal tract. But apart from that, we do also have a corticobulbar tract, very often ignored tract when exam questions are asked to students. Here also we have upper motor neuron and a lower motor neuron. The facial problems are also divided into upper and lower motor variants. So the corticobulbar tract, as we saw in the pyramidal tract, do arises from the motor cortex of the brain, that particularly the cerebral cortex in the frontal lobe. Thereafter, it comes down and it passes through the corona radiata and then enters into the genu of the internal capsule. Few fibers are also there in the posterior limb of the internal capsule, but predominantly it is in the genu. And then it enters into the crus cerebri of the midbrain, and it innervates all the nucleus of the cranial nerves here. So here what you have to remember is, as we have our peripheral nerves as the lower motor neurons, we have the cranial nerves, which are the lower neuron for the face, neck, and the certain muscles of the upper trunk. So what is the upper motor neuron here? The upper motor neuron are all the neurons that are located in the cerebral cortex, which are contributing for the corticobulbar tract. Fine. So what it does, it comes all the way here and it gives another, it gives twigs to the nucleus of the cranial nerves. Not all the cranial nerves, but the cranial nerves listed here. The exception being the olfactory and optic, which arises from the brain. The remaining all other cranial nerves arises from the brain stem, and the spinal accessory nerve has twigs onto the spinal cord also. So predominantly, all the 10 cranial nerves and arises from the brain stem. So this is what is very important here. Now, the information from the upper motor neuron are relayed into the nucleus of the respective cranial nerves. And from here, a twig arises a cell. For example, if you take this glossopharyngeal nerve, you have a nucleus of the glossopharyngeal here, and from pharyngeal. So, which is the upper motor neuron and which is the lower motor neuron here? The cells which are there in the cerebral cortex are the upper motor neuron for the corticobulbar tract, and the respective cells which are there in the cranial nerve nuclei, which gives rise for the cranial nerve or motor neuron. So what you have to remember is, when there is an injury to any of this area leading up to the nucleus of the cranial nerves, this causes an upper motor neuron symptom. And in the nucleus or below the nucleus, if there is any problem, neuron symptoms. So very similar to the corticospinal tract. But what is the difference between the corticobulbar and the corticospinal tract? The corticobulbar tract do not predominantly innervates the opposite side. 50% of the nerve fibers remains on the same side and 50% of the nerve fiber goes to the opposite side. This is applicable to the other side also. So the crossing over takes place 50% only. The 50% remains on the ipsilateral side. Whereas if you see in the corticospinal tract, the fibers, 85% to 87% of the nerve fibers crosses onto the opposite side, and only 10 to 12% of the nerve fibers remains on the ipsilateral side. Right? So here that is a major difference. So that's why you can see here, I have mentioned it like it comes here and innervates onto both the sides of the oculomotor nerve nucleus. Next is the trochlea. For trochlea also it innervates onto the either side. For trigeminal it innervates onto the either side. For abducens it innervates onto the either side. But when it comes to the facial nerve, here there is another twist. That is, the facial nerve can be divided into upper quadrant and the lower quadrant based upon the facial distribution. So this is the upper quadrant and this is the lower quadrant. This is the opposite side, upper quadrant and lower quadrant. If you divide the face into 4 quadrants, so if I divide the face into 4 quadrants, this is the upper quadrant and this is the lower quadrant. Okay, corticobulbar tracts innervates the upper quadrant on the ipsilateral side and both quadrants on the contralateral side. So when I have a problem in the left side corticobulbar tract, then what happens? It results only in the problem of the ipsilateral lower quadrant will be only affected. So remember this, we have a lot of topics to discuss and differential diagnosis to be done using the corticobulbar tract. We are coming up with the later on. So just as of now, remember this. So likewise, if you see all other cranial nerves are similar, but the hypoglossal nerve also do not innervates the ipsilateral side. It innervates only the contralateral side. So when the patient has a left-sided corticobulbar tract involvement, the opposite side functions will be lost. So upper motor neuron and lower motor neuron for the corticobulbar tract is clear with interchangeable thoughts on this, but let me clarify this. Bulbar means the brainstem. And in the next class,
So that's it about the corticobulbar tract. The main purpose of showing you that video is the classroom, the board teaching would be much better for explaining this particular topic than just showing it through this sort of slides. Okay, so now I think if you want to take a break, you can take a break. Otherwise, if we want to continue, we can continue. What is your idea? Shall we give a break after 2 hours? That is probably by 11.
Yes, sir. It's a 5 minute or 10 minutes break, sir?
No, we can. If you want, we can have 5 minutes of break.
Yeah.
Yeah, fine.
Yes, it's a 5 minute break.
Okay, thank you. So now we'll see about what is the function of the extrapyramidal system, which is very vital. Um, yeah, you're able to see this screen?
Yes, sir. Yes, sir. The
Yeah,
function of extrapyramidal system.
yeah. So the difference between pyramidal system and the extrapyramidal system is the pyramidal system is useful for voluntary control and skilled activities. We have seen that it is predominantly influencing the flexors, whereas the extrapyramidal system is useful for maintaining the constant tone of the body. Constant tone of the body is needed in the anti-gravity muscles of the body. You know, the anti-gravity muscles are the one which are constantly fighting against the gravitational force in maintaining the body posture. So they are predominantly extensors in the body, and the extrapyramidal tracts are influencing the extensors of the body, human body. Um, so what happens when there is a problem in this extrapyramidal tract? It results in hypertonia or a sort of a rigidity, which we are going to see in subsequent classes. Why there is a spasticity when there is a pyramidal involvement, and why there is a rigidity when the extrapyramidal involvement is there. Okay, so what are the cells which are giving rise for the extrapyramidal system? What are the extrapyramidal system tracts of the extrapyramidal system? We know that it is the rubrospinal, tectospinal, olivospinal, and vestibulospinal. Okay, so the functions of these things are just a minute. Yeah, so the first tract is the rubrospinal tract. It arises from the red nucleus in the midbrain. You can see here there is a red nucleus in the midbrain. This gives information down to the spinal cord. This is called as the rubrospinal tract. But one thing we should remember, that this also receives information from somewhere other part. That is the significance of the extrapyramidal system. We saw that pyramidal system are starting from the cerebral cortex, but the extrapyramidal system do not arise from the cerebral cortex, but always have an influence from the cerebral cortex. So the influence for the red nucleus is coming from the cerebellum and the cerebral cortex. So the input for them coming from the cerebellum and the cerebral cortex. From the red nucleus, this tract runs out, goes opposite. That is, it is crossing to the opposite side, and it descends through the pons medulla, and it comes to the spinal cord. Remember that it is crossing to the opposite side. So what is this? Red nucleus to the spinal cord. So it is called as rubrospinal. What is the function of this? Involved in movement of the distal limbs and also regulates the tone and posture. Okay. One thing you have to remember of rubrospinal tract is it is influencing mostly the upper limb. Remember that it influences the upper limb more. It also influences the flexors of the body. This is the only tract in the extrapyramidal system that influences the flexors of the upper limb more than the flexors of the lower limb. Remember this. I will tell you what is the significance of this when I'm teaching you the Babinski sign or the extensor plantar response. So the rubrospinal tract is going to control or contribute to the flexor activity of the upper limb predominantly. Okay, apart from that, it maintains the tone in the body. Here it is written as hand and feet, but it is mostly hand and very few percentage in the feet. Okay, it receives information from the cerebellum and the cerebral cortex. Next is the vestibulospinal tract, a very important tract. The nucleus of the tract is located in the vestibular nucleus, which is located in the pons and the medulla. This nucleus, as I told you, should should receive information from some other part of the body. So this receives information from the otolith organ, that is the vestibular apparatus of the ears, inner ear. Okay, from the inner ear, the vestibular part sends information about the position of the head in relationship to the body and position of the body in relationship to the environment. When I say the relationship between the position of the head and the body, when I move my neck up and down, that is the relationship of the head changes in the relationship of the body. When I am traveling in sitting inside a car, or when I am traveling in a lift, then that means my body is in relationship to the environment. Or even when I'm walking, when I am doing sit to stand. So all these activities, my head and my trunk moves in relationship to the environment. So both these informations are gathered by the upper part of your ears called as the vestibular organ, and this information is sent to the nucleus of the vestibulospinal tract. This information from there on is relayed onto the same side, and it is relayed to the same side spinal area. So this is not crossing. Remember, vestibular is crossing, vestibulospinal is not crossing. So what is the function of the vestibulospinal tract? It is excited, it influences the same side extensors. Okay, it is inhibitory to the flexors. Very importantly, you have to remember this. It is inhibitory to flexors and excitatory to the extensors. As usual, it controls the muscle tone and the balance, and the head movement is detected by the vestibulospinal tract. Fine. Next is the reticulospinal tract. Very important structure in the body is the reticulospinal tract, reticular activating system. So this reticular activating system is present here, which is running from the medulla to the pons. You can see this is placed more medially. This is the reticular activating system, RAS. A collection of nucleus in the pons and the medulla are called as reticular activating system. So what is the role of this reticular activating system? It is going to uh, uh, it is a mostly like a switch on switch off mechanism in your body. When you sleep, this reticular activating system is off, but when you're awake, the reticular system is on. That means when you want to sleep, the body do not switch off all the parts of the sensory receptors separately. It switch off the reticular activating system. It is more or less like a main switch in your house. When you switch off that, all the sensory receptors will stop working. The reticular activating system is for the human body. That is why if you get a head injury onto the brainstem that is affecting the pons and the medulla, very deep inside, you have this reticular activating system. That's when the patient goes for a complete coma. And the recovery of this patient is going to be very meager and weak because the reticular activating system uh, is getting damaged only when most of the spinal cord gets damaged. So it is located so centrally. So this reticular activating system sends information down to the spinal cord, and this information is relayed by means of the reticulospinal tract, which is the third tract in the uh, uh, extrapyramidal system. Fine. So they have two portions, pontine portion and the medullary portion. So what is the role of the pontine portion? The pontine portion of the reticulospinal tract runs ipsilaterally. That means it does not crosses to the opposite side, and it is also remaining on the ipsilateral side. Okay, so it runs ipsilaterally, and function is it's excitatory to the axial extensor muscles. So axial means trunk extensor muscle. It is going to produce excitatory influence. So the medullary reticulospinal tract also runs ipsilaterally, okay, but very few fibers crosses, but predominantly it remains on the same side, inhibitory to the axial extensor muscles. So it can inhibit the axial extensor muscle. But remember that this is not going to stimulate the flexors. It is not an excitatory to the flexors. The medullary is inhibitory to axial extensors, and the pons is the excitatory to the axial extensors, and it remains ipsilateral. So far we have seen three. In that only the reticulospinal tract crosses to the opposite side, but the vestibulospinal and reticulospinal remains on the same side. The last one is the tectospinal tract. You have known about the tectum, tegmentum, all these things in the midbrain. So the tectum is an important part in the midbrain. This tract receives information from the eyes. One thing I forgot to tell you, The reticulospinal tract, where it receives input from, it receives inputs from the afferent sensory inputs from the sensory areas, like how your touch, temperature, pressure, the proprioception, all these movements that are happening in your body, somatosensory inputs are going to be the inputs for the reticulospinal tract. And also the vestibular stimuli which is coming from the otolith organ are also going to be the inputs for this reticulospinal tract. Now, the last one is the tectospinal tract. I told you the inputs from this is from the eyes, from the visual stimuli. If some object is approaching you very fast and you want to react to this object, then your tectospinal tract is going to be active. So see, you can clearly see that God has given you all sensory stimulus, one particular tract to react for, like your vestibulospinal, your reticulospinal and tectospinal. Now, tectospinal, what is the function of tectospinal? It is going to involve in the control of the neck muscles in response to the visual input. What happens when you're when something is approaching your eyes, you just rotate your head to avoid the problem. So it is going to control only your, mostly your neck muscles, and it is again an excitated to the extensors of the neck and mostly the upper trapezius and all those areas. Fine. So do they cross? Yes, they do cross, and they go to the opposite side. That is visible in this diagram. So two tracks are crossing to the opposite side and two tracks are remaining on the same side. Rubrospinal and the tectospinal crosses to the opposite side, whereas the vestibulospinal and the your reticulospinal remains on the same side. So what is the difference between the pyramidal tract and extrapyramidal tract? We have already seen that there are the lateral corticospinal tract, the corticobulbar tract are called as the pyramidal. Here you have rubrospinal, vestibulospinal, reticulospinal and tectospinal. The cell bodies of these pyramidal tracts are located in the precentral gyrus of the cerebral cortex, but the nucleus of the cell bodies of these things are located in the brainstem. The pyramidal tract descends directly without synapsing and it goes directly to the spinal cord. No direct connection of the motor cortex or the basal ganglia or the spinal cord, but via the midbrain. So the informations, the extrapyramidal tract receives information from elsewhere part of the body and conveys that information to the spinal cord. So 80% of the corticospinal tract crosses to the opposite side. Okay, you can see that we told that it is the anterior and the lateral corticospinal tract. Majority of the extrapyramidal tracts, some crosses and the others are uncrossed. Two of them are crossed and two of them are uncrossed. So what is the function? We know that it is fine movement. Here it is motor fine movement and flexor dominant. Here it is the posture, tone and the extensors of the thing. Only tract that maintains the flexor of the body here in extrapyramidal system is your rubrospinal tract. Got it? So fine. Now we are going back to our previous slide. Okay, so now we have completed about the tracts. Now we are coming to the cerebellum. You have any doubts now? You are welcome. You can ask me now. Any doubts? All are awake? Okay, so I'm going to the functions of the cerebellum. I got one response. Yes, sir. Okay. Thank you, Shalini. I can understand that at least I'm talking to one person. Yeah, it is very tough to teach online without seeing the audience and their reaction, because in a classroom, if you have any doubts or any misunderstanding. Your face can identify. With the face I can ask, do you have any doubts? But here I don't see anybody, so it is going to be tough for me. So if you have any doubts, please stop me at any time. I am ready to explain to you. Thank you, Alan. Thank you so much. Okay. So now what is the role of the cerebellum? As I told you, cerebellum is a comparator. It compares what is the actual intended movement and what movement is actually happening. Because if only it compares, you can rectify, we can correct. Human nature is like when you start riding a cycle, initially you do a lot of mistakes. But how you correct these mistakes? By means of the cerebellar input, which says that whatever you are intended is not happening. So you have to change. That is very important. Niraimati ma'am. Thank you, Niraimati ma'am. Oh, it's a Tamil name, I forgot. Uh, Sneha ma'am, thank you. Doubt about facial nerve nuclei in the corticobulbar tract. Okay, so the facial nerve nuclei, you have in two nuclei, right side and left side. The right side corticobulbar tract will supply the contralateral full facial nerve, that is the upper and lower part of the facial nerve, facial nucleus. But on the ipsilateral side, it supplies only the upper quadrant. Got it? On the left side, corticobulbar tract will supply the left side upper quadrant of the facial nuclei alone. On the opposite side, it will supply both the upper and lower. So that is the difference in the others are not divided into quadrants. So the right side will supply the right side upper quadrant and the left side upper and lower quadrant. So invariably, the upper quadrant have bilateral representation, but the lower quadrant has only one-sided representation. The opposite side is the one which is going to control the lower quadrant. So in case if I have a right CVA, my lower side upper quadrant will be affected, but not always. That is what here. Not always all right-sided CVA will cause a left-sided lower quadrant. Where is the location of lesion? That is very important. Whether it is there in the cerebral cortex, whether it is there in the brainstem, whether it is in the midbrain, pons or medulla, all these things determines whether the patient will get a same-sided facial palsy or a opposite side facial palsy. That is a very tricky thing. We will see in the last class. Got it? You're clear, Sneha? Thank you. So I said cerebellum is a comparative machine in our body to act as a timing device. So when you are producing some movement, we come across this word called as timing in cricket. What a timing by the batsman, that means the time at which he hits the ball and the force with which he hits the ball. So the timing of any movement is very essential for the movement to look very smooth and to consume less energy. For example, if I want to touch a point like this, I have to exactly touch the point. I cannot go wander around and then finally touch this point. So who is helping me in doing that? That is my cerebellum. That is why when there is a cerebellar loss, my coordination becomes affected. I don't touch the target exactly. I undershoot or either overshoot and finally come to the target. So this is called as timing of movement. Which muscle should contract in which sequence is determined by the cerebellum. And how long they should contract is also determined. Next is the initiating and storing movement. For example, the movement memory, that is activity which you have already done, you get a familiarity, and later on if you keep on doing that movement, it becomes learned movement, and whenever you're repeating that movement in your future, you find it very easy to do that movement. So who is storing these movements? One of the apparatus storing the movement in your body is your cerebellum. What memory it stores? It stores what is the timing of movement which is used previously. what was the resultant of the movement which you used previously. Would be reminded by the cerebellum. What timing of movement you used, whether it was a successful movement or a non-successful attempt, that will also be remembered by the cerebellum. So it has an excitatory influence on the tone. So it will always produce an increased tone. When the cerebellum is stimulated, it will produce an increased tone. So when the cerebellum is lost, that is why you get a hypotonia. So why cerebellum should always influence the tone? Because cerebellum is also a balance regulating center and equilibrium center, which constant positivity on the muscle tone by influencing the gamma motor neurons of the spinal cord. So once the cerebellum is lost, the excitatory neuron is also going to be lost and the muscle tone is going to go down. Okay, got it? So now we are going to see some of the important structures in the brain. So when I was studying my undergraduation or post-graduation, uh, my major problem in understanding neurology was these terminologies. When somebody tell amygdala, when somebody say septum pellucidum, I'll be irritated because I don't know what are they, where are they. But later on, I came to know that more than knowing where are they, it is very important as a function of them. So now I will elaborate to you some of the important structures in the brain. You can remember very easily if you go through this for 2 or 3 times, but you can and that will help you in explaining nervous system and movement and differential diagnosis to people. Okay, the first structure is called as the amygdala. This is located inside the insula. So this center, the fear factor is the function of amygdala. When the amygdala is activated, it is very impossible for you to make a patient activities which he has a fear attached to it, because amygdala is important for processing the fear. You might have seen people who walk on the skyscrapers. They ride cycle on the mountains, but certain people cannot do that because of the influence of the amygdala. How this amygdala is being trained, the emotional response you give to situations is dependent on the amygdala. So it is also the center for the autonomic nervous system, that is your uh, mm, sympathetic and the parasympathetic nervous system. Next is the cerebellar peduncle. So this is insula. Here inside the insula is your amygdala. Again, insula is being shown opening the cerebral cortex. Okay, now coming to the cerebellar peduncles. The cerebellar peduncles are the one from where the cerebellar fibers, then the information from the cerebellum reaches into the brainstem. So invariably they are more or less like a connecting source for the cerebellum with which it is getting connected to the brainstem. Likewise, you have cerebellar peduncles here. You also have a cerebral peduncle. The cerebral peduncle is the one which connects the cerebrum with the brainstem. So you can see this, the green color one is the cerebral peduncle. What is the role of these two peduncles? They relay the information to the from one part of the brain to the other part of the brain based upon the name. If it is cerebellar peduncle, it is going to relay the information from the cerebellum, and if it is cerebral, it is going to relay the information from the cerebrum. Next is your very important structure called corpus callosum. The corpus callosum is the one which connects two hemispheres. All the information from the right sided hemisphere to the left sided hemisphere are transmitted through this corpus callosum. So you can obviously imagine if there is a problem with corpus callosum, the problem will be in the coordinated activity of two limbs. When you want to throw a ball from the left side, you can easily catch it on the right side. But when this particular structure is affected, this interlimb coordination, interlimb coordinated activity is going to be lacking. That is going to be affected because the right side hemisphere cannot communicate with the left side hemisphere because of the information. But how God has given this so beautifully, it is a very extensively long structure, and it is supplied by 3 blood vessels. And in case of any infarction or hemorrhage to this structure, only 1/3 of the structure can be affected and the remaining 2/3 becomes normal. So that is why you cannot see corpus callosum completely involved in any ischemia or very important structure, hypothalamus, hippocampus. So you can see this is the connection area between the amygdala and the basal ganglia nucleuses. So what is the role of hippocampus? It is very important for the memory. When you want to navigate from one place to another place, when you are navigating on a ramp, when you're navigating on a stair, uh, so this geographical idea and the geographical memory is being stored in the hippocampus. People who have a very good strong hippocampus once travel through difficult areas through bike or car or something like that, they can travel very easily next time. But people have a very poor geographical idea if they don't have a proper hippocampus, and they keep on seeing their Google Maps every time to go for their destination. I'm a very poor person in hippocampus because even if I travel 5 to 10 times in a road, I won't remember that road. I always look into the Google map. And in fact, there was a study which is done, which says that after the introduction of the Google Maps, your hippocampus is slowly shrinking. That means you're not using your hippocampus to navigate anymore. You are seeing the Google Maps to navigate. So this is one disadvantage of technology. You can also see some other structures here apart from the hippocampus. You can see the thalamus here. Because it is below the thalamus, this area is called as the hypothalamus. You can see the basal ganglia in relationship to thalamus, which is very closely related to the amygdala here. Fine. So what is the role of the hypothalamus? It regulates appetite, thirst, sexual drives. The hypothalamus is all, we can say, all humanly activities, humanly needs, physiological needs of a human being are mostly regulated by the hypothalamus. Very important need for a human being is appetite, thirst, without which we cannot live. And the third thing is the sexual drives, without which our next generation may not be possible. And these 3 important structures are controlled by the hypothalamus. And that is a very important structure. Now, what is the role of the thalamus? Thalamus is a very important sensory integrating center. Now I am talking to you on this forum. You are listening to my voice, okay? And at the same time, you will also be seeing some of your family members moving in your house. You may also listen to some of the sounds from the AC, fan, or some birds or animals screaming outside. But your attention, I perceive, is only towards me. Am I right or not? How this is possible? Why your brain is not processing the other sensory inputs which are received from the environment? That is because the thalamus is the one which filters out, which are all non-significant sensory inputs that are going towards your conscious level. It will not allow all the unwanted sensory inputs to go to your conscious level, that is to your cerebral cortex. It will allow only meaningful required sensory information to the brain. So as of now, that is my talk. If suddenly you get a very bad smell in your room, or sometimes if you feel like some LPG gas or some electrical circuit smell is coming in your room, that some burnt smell is coming in your room, suddenly your attention will focus onto that particular thing. your attention on my talk will be less, because the thalamus will shut down my sensory input towards the brain, and it will allow the olfactory information to go. But one important thing you should know is the only sensation that can reach the brain without going to the thalamus is your olfactory sensation. That is your sense of smell. All other sensation like your visual, your auditory, your superficial sensation, deep sensation, all these things will definitely go to the thalamus, and then only even the taste sensation will go to the thalamus, and then only it will go to the brain, to the spinal, to the cerebral cortex. But the sense of smell can directly reach into the spinal cord, to the cerebral cortex. I will tell you one simple example for this in Ramayana. When you know that Kumbhakarna is the brother of the Ravana. So Ravana was king of monsters, and he kidnapped Sita and all those things. You know, there was a fight between Ravana and Rama. So that time, what Ravana is doing, he's sending one by one of his brothers to fight against Raman. But every time they send, they are failing. But his best weapon is the Kumbhakarna. Kumbhakarna is a one who is very tall and gigantic person, who used to sleep for 6 months and who used to be awake for 6 months. So the war has happened in a time when Kumbhakarna was sleeping. He was in hibernation. So how to wake him up? Ravana did not know. He sent a lot of animals like the elephant, the horses, to kick him and get him up, because he's such a huge person. It did not wake him up. He sent his soldiers to poke him with knives. That also did not wake him up. But finally, what he did, he sent the food substances of his favorite choice, and he made the smell to reach his olfactory buds. So what happened? He, with the smell of this food, he woke up. So I don't know whether this is designed physiologically or mythologically, but this story is a very significant story. I correlated it with the thalamus. So why I'm trying to say this is the smell sensation can reach the brain very faster. It can also be applied in our rehabilitation of coma patients. When we give noxious stimuli to the patients who are in coma, to stimulate their brain directly, because we know that it is not going to relay through the thalamus. Even patients who have thalamic infarction will have processing problem in the sensory information. We, in case if they are in coma, we can use the olfactory sensation. Got it? That is the role of the thalamus. That's why when I'm teaching you about the tracts, I told you about the lateral spinal thalamic tract and the posterior column tract. All of them go to the thalamus, then only it goes to the cerebral cortex. So there are two things, inferior colliculus and superior colliculus in the midbrain, the next structure. The inferior colliculus is auditory, superior colliculus is relaying the information of the visual information. Okay, I remember that when you see something, you believe more. So the visual informations are superior. Auditory can be always deceiving. You will anybody can cheat you by means of giving a fake calls. So auditory means inferior. So I remember this: superior colliculus for visual stimulus, inferior colliculus for the auditory stimulus. Okay. Okay. Next is your internal capsule. So the internal capsule, this area is called as the internal capsule. You can see the fibers from all parts of the body are coming. So all parts of the cerebral cortex are coming in a radiant manner. This area is called as the corona radiata. All these fibers condense here. You can see this condensing area like a boomerang shaped structure. This is called as the internal capsule. If you want to see the internal capsule in the MRI or the cross-section study, you can see this here in this part. This boomerang shaped structure is called as the internal capsule. So for an internal capsule, who are all the adjacent areas? Thalamus is the adjacent area. Basal ganglia is the adjacent area. Most of the basal ganglia nucleus are located near the internal capsule. Your lentiform nucleus and the caudate nucleus are very close vicinity to the internal capsule. So next is your periaqueductal gray matter. This you might have studied in your Clayton's electrotherapy, that this periaqueductal gray matter is a very important structure in the pons, which activates the descending pain suppressing system. You might have known about the Raphe nucleus, periaqueductal gray matter and the Raphe nucleus, which activates the descending pain suppressing system, thereby reducing your pain in the body according to the pain gate theory by Melzack and Wall. So they are located in the pons, and they are one way or other responsible for the release of the endogenous opiates called endorphin and enkephalin. So they are going to modulate your pain experience, and they are very important uh, centers for pain. So next is your basal ganglia. We have already seen enough about basal ganglia. So the gangliocapsular region is nothing but the combination of the basal ganglia and the internal capsule is called as the gangliocapsular region. Last but not least is your pineal body. The pineal body is the one. Okay. So the pineal gland is located here. Okay. So this is the pineal gland. And what is the role of the pineal gland? It regulates some of the hormones in your body, which are sexual hormones. And very important hormone it regulates is your melatonin. Melatonin is best known for its role to play in regulation of sleep pattern. If you have insomnia, there may be a problem with the pineal body. So sleep pattern is being disturbed these days when you are sleeping in an abnormal timing, and that can invariably influence the hormones of your body, particularly the hormones like melatonin and sexual hormones in your body, because the regulatory center for sleep pattern, I'm not saying about the sleep, it is sleep pattern, and the melatonin and other hormones is the same. Okay, so you should know the association now. There are some neurotransmitters in your body. They are very important. They are the one which determines how your body is, because the nervous system communicates means of the neurotransmitters. You have five main neurotransmitters. The first one is the acetylcholine. Acetylcholine deficiency leads to disease and myasthenia. And in case if receptors of the acetylcholine are affected, then the condition is called as botulism. Okay. And dopamine is involved. You know about Parkinsonism and schizophrenia. There the dopamine is affected. Dopamine has dual role. It has an excitatory role in the direct pathways of the basal ganglia, and it has an inhibitory role in the indirect pathway. When the direct pathway is activated, the movements are excited, movements are facilitated. When the indirect pathway is inhibited, the movement pathways are excitatory. That is, there are two pathways in the basal ganglia mechanism, direct pathway and an indirect pathway, which is really out of the scope of this presentation, but still I'm just telling you. So dopamine has different role in these two pathways, direct pathway and the indirect pathway. I would suggest the students to go and read into what is direct and indirect pathway mechanism in the basal ganglia that results in Parkinsonism. Next is the glutamate, which is very important neurotransmitter, which is produced from scar cells of the brain. When the scar cells are in the brain, sudden discharge of glutamate can cause epilepsy, and it can also cause migraine, and sometimes, very rarely, it can cause stroke. So the onset of epilepsy and onset of the migraine is a big debated subject in neurological examination. What is triggering these two is of big debate. Next is the GABA aminobutyric acid, which is responsible for sleep. And again, it is responsible for the anxiety related epilepsy happens because gamma, this GABA is a very important pacifying neurotransmitters in the body. Last but not least is the serotonin. Serotonin is it is useful for the arousal, pain modulation, very importantly, emotional outcomes. When I ask any of you in this group, what was your very happiest moment in your life? What was the happiest days in your life? What you will say? You will say definitely about your school days. Am I right or not? Or your childhood time? You will say, sir, I was very happy those days. I did not have much responsibilities. I was so happy. I was never depressed. My arousal levels were high. I was having a very good sleep, because the serotonin levels are high when you are a child. As the age progresses, out of all these 5 neurotransmitters, your serotonin goes for degradation more faster, and the dopamine is the one which goes for degradation very late. Okay, so serotonin will be lost from your body at the 30s or 40s, and they comes to the minimum level in 30s and 40s. That's why you can see your father, your grandfathers are all not that happy like a kid, and you guys are also happy. But how to keep the serotonin levels high? If you keep laughing and smiling and you give more positivity to your body, the serotonin levels degradation will be diminished. It is proved scientifically. So the basis for the laughter therapy was because of the fact that serotonin is increased or maintained when there is the smiling and laughing takes place. But it failed miserably because you need a sensory input for that laugh. Without a sensory input for the laugh, if you keep on laughing like an idiot, you are not going to increase the serotonin level, because that is also proved by science. Now that's why you don't see the bunch of idiots standing in the garden and laughing these days, which was uh, what is it, a practice 10 years before. Now it is gone. Yeah, the laughter should come from the real life situation, not from an artificial source. Okay, my dear friends, this is the internal capsule. I told you, you have anterior limb, the genu, and the posterior limb. The anterior limb conveys the extrapyramidal tracts. The genu transmits the pyramidal tracts, particularly the corticospinal and the corticobulbar. And the posterior limb is concerned with the sensory relay. Okay, so with this, we come to the end of this presentation. We have got program on the approaches in stroke rehabilitation, which commences today evening by 5 to 8, and it goes for 2 weeks, that is 18th and 25th. If anybody is interested, you can join this program. Okay, so this session is over for the anatomy and physiology session is over. In the next session, what we are going to see is about how to classify the neurological conditions for your assessment basis. If you have any doubts, you can please ask me now. Always when we have a class in my rehab, uh, I expect you people to discuss again. Thank you, Prabhakar. Once again, thanks to Shalini. Yeah, we can take 5 minutes break and we can be back. The neurological conditions under 4 broad categories. So Uh, this is purely based on my classification. You can't see this in any books. So if there is any flaws, you can excuse me and we can discuss about this. In all my understanding, I have divided these conditions into these four main categories, because the assessment and treatment more or less, I won't say exactly, more or less are similar for these categories. First category is the upper motor neuron lesions, where you can categorize your stroke, traumatic brain injuries, multiple sclerosis, brain tumors, brainstem disorders, and spinal cord injury in the upper motor neuron lesion. Okay, I mean to say spinal cord injury, not the spinal nerve injury. There is a lot of difference between those two. Next is the lower motor neuron disorders, where you have your peripheral nerve lesion, peripheral neuropathies, peripheral neuritis, entrapment neuropathies, radiculopathies, conditions like Guillain-Barré syndrome, poliomyelitis, which is the anterior horn cell disorder. Next, we can also have, next category is the movement disorder, where the problem is not with weakness or paralysis or anything else. It is the problem with the quality of the movement. So I can say the basal ganglia is the one which is responsible for producing the background activity for the movement, that is maintaining the tone of the movement muscles. So any problem in these structures can cause either an reduced timing of movement or increased timing of movement. That is, movement time is increased or movement time is diminished. Paucity of movement or abundance of movement. So the uh, basal ganglia is a very important structure, and along with that, your cerebellum is also playing an important role as a comparing component of the movements. So these two things put together in the movement disorder. Normally, if you go to the neurological books, movement disorder means they will say only Parkinsonism, chorea, athetosis, balismus, hemibalismus, all these things. But I have included cerebellar disorder here because the management and assessment also from a physiotherapist point of view are somewhat similar in controlling the quality of movement rather than the quantity of movement. Okay. Next, the fourth classification is the myopathies, neuromuscular junction disorders, where the problem is not with the nervous system, but the problem is in the interface of the nervous system. Who are the interfaces? The muscle is the major interface for the nervous system. You can classify your muscular dystrophies, myopathies, inflammatory muscle disease, and neuromuscular junction disorder, whether it is a pre-synaptic disorder or the post-synaptic disorders like myasthenia and botulism, respectively. Okay, so this is the four main classification. So I'll tell you about upper motor neuron lesion now. The major difference between the upper motor neuron lesion we have already seen. The upper motor neurons are all located in the cerebral cortex. Okay, for the pyramidal tract and the that is the corticospinal tract and the corticobulbar tract. The upper motor neuron are located in the cerebral cortex. Where is the upper motor neuron for the extrapyramidal tract? They are all located in the brain stem. When I say rubrospinal, the red nucleus is the upper motor neuron. When I say vestibulospinal, the vestibular nucleus is the upper motor neuron. Tectospinal, the upper motor neurons are there in the tectum. Uh, and the last one is your reticulospinal tract. So for that, the upper motor neurons are there in the reticular activating system of the pons and the medulla. Okay, so who is the lower motor neuron? The anterior horn cells here in the spinal cord are the lower motor neuron. So any problem that happens from this area to just above this area, then this is called as the upper motor neuron lesion. Any problem in the anterior horn cells and subsequently down to the peripheral nervous system, that is called as the lower motor neuron lesion. Okay. Clear? So this is a very important exam questions, and understanding wise, the clinical feature wise, everything is different for these two conditions. So we have seen all these things. So now we'll see what are the signs and symptoms of upper motor neuron lesion. Significantly sudden onset. Most of the time, the patients will complain that there is a sudden onset. Yesterday night, my grandfather was seen lying on the floor, and when we checked, his consciousness was not there. He was not oriented. He was not able to lift his upper limb and lower limb, and most often these symptoms are sudden. When there can be insidious onset, when there can be a gradual onset, if there is any space occupying lesion in your brain like a tumor that grows very gradually. You have various types of tumors which can grow within weeks, tumors which can grow for years, tumors which can grow for months, based upon what is the cell type of that tumors. So most of the time when there is a space occupying lesion like a tumor, the growth and the onset will be gradual. But apart from that, the most often CVA associated with blood problems, the vascular problems, are sudden onset. There may be some history of trauma also in case of a hemorrhagic stroke. The patient might have fallen, and because of which he might have had a head injury. Head injury can also be a significant contribution. Here, the vital monitoring is very important. You can see a lot of abnormality in the vitals because your respiratory centers and your cardiovascular centers are also involved in the upper centers. Whereas you won't see this in the lower motor neuron lesion. That's why I'm saying this. There will be a lot of coexisting systemic disorders. Most of the time, the patient will be hypertensive or a diabetic or a thyroid abnormality with any metabolic disorders. So coexisting disorders can always be there. And there can also be some history of infection, like in case of a meningitis or any other cortical infection, or post-encephalitis can also cause the upper motor neuron symptoms. Okay, so there will be most of the time there will be problems with cognitive and perceptual deficit if there is a huge upper motor neuron lesion, but you won't see all these things in the other three categories. Whenever there is involvement of the cognitive function and the perceptual function, it is always going to be a upper motor neuron lesion. I won't say motor here. I would say the involvement of the cerebral cortex, because motor means movement, things which are related to movements. The motor symptoms can coexist when there is a cognitive and perceptual deficits. Okay. Next is hypertonicity, that is spasticity will be there. One thing you should remember, that all upper motor neuron lesion do not produces hypertonicity and hyperreflexia. It is a very important thing you have to remember. If there is a pure cortical stroke, if there is no involvement of the subcortical structure, only the cortex of the brain is involved, then you will see only stroke producing hypotonicity and hyporeflexia. It will be entirely different. You should not confuse that. This is one instance where you will get hyporeflexia and hypotonia, that I will explain you in subsequent in a board teaching. Second thing is when there is a cerebral shock. What is meant by cerebral shock? Like a spinal shock. When a person is undergoing stroke or CVA, when he is having a profuse edema in the brain, when he is having an active process that is going on in the brain completely shut down all its function. So when it goes for a shutdown, what happens? The tone and reflexes are going to be diminished and absent. Not diminished, absent. So cerebral shock can resolve in 2 days, it can resolve in a week, it can resolve in sometimes 6 months to 8 months together. But most often, the cerebral shock resolves when the active inflammation or the edematous process in the brain subsides, and it takes almost 3 to 4 days on an average for 76% of the patients for the spinal shock to resolve. So you have to remember that when there is a pure cortical stroke and there is a cerebral shock, the patient will have hypotonicity and hyporeflexia, even though they have a upper motor neuron lesion underlying. And if there is a problem in the basal ganglia, the patient will not have spasticity, or they will not have hypotonia or hyperreflexia. They will have rigidity. Rigidity is classically present only when the basal ganglia is affected. We will see that in the Parkinsonism. Next is hyperreflexia. Lack of voluntary control. You won't say that there is a weakness of the muscle. Whenever you say this word weakness, that pertains to the muscle. You should not use this word weakness for upper motor neuron lesion. You should say the voluntary control is lost. This is how I studied when I was doing my post graduation. My teachers all taught me that it is all about the lack of voluntary control, because your upper motor neuron are responsible for executing the control. But now there are a lot of EMG studies which are done, which states that in stroke patient you do have weakness of selective muscles. That is because of the representation area in your brain and lack of activity of this area. You get a lot of individual muscle weakness. But for the convenience of this teaching in this class, I would rather say that it is not weakness, it is the voluntary control loss. Fine. So you can do extensive study on that to understand the advanced aspect of this. So this is the basics. What I'm telling is the basics. You can go in search of advanced knowledge. Second is sensory deficit will be there, but it will be based on the cortical distribution. What is meant by cortical distribution? You have your somatosensory cortex in your brain is mapped according to your body parts. All the body parts in your human body is represented in your somatosensory cortex. For example, there is one area for hand, one area for shoulder, a large area for hand and the lips and tongue. Likewise, you have different areas in the brain. If the area of upper limb is affected because of stroke, your sensation of the upper limb on the contralateral side will be diminished or absent based upon the lesion. So this is called as cortical distribution. How the body part is represented in the brain, in which part of the brain you have infarction or hemorrhage or any tumor, based upon that you will have your sensory distribution. Next is superficial, deep and cortical sensation can be affected. Here only only the upper motor neuron lesion you are going to assess the cortical sensation. What are the cortical sensation? Your 2-point discrimination, baragnosis, stereognosis, graphesthesia, all these things are called as cortical sensation. As that is not in the scope of this presentation, I'm not going to deal with them, how to assess them and all, I'm not going to deal. But for you to know, superficial sensation means touch, temperature and pressure. Deep sensation means proprioception, kinesthesia and your vibration. And cortical sensation means a sensation which uses both these two sensations, that is a superficial and deep sensation, are being utilized and analyzed by the cerebral cortex, and they come out with some decision making. So they are called as cortical sensation. A classical example of cortical sensation is if I give a cotton in one hand and an iron piece in another hand without seeing which is what object, you can say that that iron is more heavier than the cotton. That is because your baroreceptors in your hand are sending information to the brain, and the brain is able to take a decision upon what is the weight of the objects that is held in your hand. That is called as baragnosis. If you lose this ability to identify the weights, we call it as baragnosis. So next is the balance disorder in upper motor neuron lesion. If the lower limb and the trunk musculatures are affected, definitely you will have balance disorders. But there are conditions like your middle cerebral artery infarction, which will not affect the balance much compared to the anterior cerebral artery infarction, because your middle cerebral artery represents more of the upper limb distribution area for the motor, and the anterior cerebral artery supplies the areas that are representing the lower limb. But for sure you will have balance disorder, but how much is affected is based upon which artery is involved. So definitely you will have some balance disorders. When balance is affected and voluntary control is affected, definitely you will have a problem in the gait, and it is going to result in a much bigger functional deficit compared to a lower motor neuron lesion. So now comes a differential diagnosis, that is what is a decorticate rigidity and what is a decerebrate rigidity, which is seen in the upper motor neuron lesion. I can suggest you to remember that decorticate in this word COR, core, which is called as core means what? Center. When the upper limb is towards the core, you can remember that that is a decorticate rigidity. In decerebrate rigidity, the upper limb will be away from the core. So just for you to remember what is decorticate rigidity. So what is the physiology behind here? Decorticate. That means the cortex is it's losing its influence on the body. Okay. So once the cerebral cortex is taken out, so this is the cerebral cortex, this is taken out. So what is remaining? The pyramidal tract is gone, because the cortex is from where the cerebral cortex, pyramidal tract is arising. The corticobulbar and the corticospinal tract are taken away. The remaining thing is the extrapyramidal tract. Because the pyramidal tract is gone, the remaining is the extrapyramidal tract, because the extrapyramidal tract arises from the brainstem, so they are intact. Okay, so decorticate, you have to draw a line here. This side is gone. So you have seen that the pyramidal tracts are predominantly extensor in nature. So they will dominate the flow of the extensor extrapyramidal system will be more, and the upper trunk and the lower trunk will be influenced mostly by the extensors. But you may be asking me one question, sir, how come the flexors of the upper limb is active? Why the patient is having the flexor in this controlled posture? Because I told you the rubrospinal tract has an influence on the flexors of the upper limb. That is the only tract which is intact here, which is controlling the flexors of the upper limb. So the hands will be in this position. So that means that you are able to do a purposeful extensor activity. No, you can't do a purposeful extensor activity or a purposeful flexor activity. This loss of the cerebral cortex will render all these body parts non-functional, but simply the posturing will be like this. Okay, remember why the upper limb is in flexed posture? Because of the rubrospinal activity which controls the flexors of the upper limb. I told you that it influences the upper limb more, but the lower limb it is not influencing that much. That is why the extensors of the lower limb are active still. The rubrospinal is not able to influence the lower limb. Whereas this next category, decerebrate rigidity, that means the cerebral cortex as well as the cerebrum, the remaining cerebrum, that is the subcortical structures, are all cut off. So subcortical structures, I mean to say, is your brainstem also. So when I say this entire cerebral cortex, the cerebrum, the red nucleus are all affected here. So the rubrospinal is also not having an influence on the body. Only the other systems which are below the midbrain, that is your reticular activating system, the vestibulospinal tract, all these tracts are in, they are all excitatory to the extensors. They are intact. So the upper limb is also extended, the lower limb is also extended. Now, if you have any doubts, you can ask me. So why this is used, decorticate and decerebrate rigidity? You go to a ICU, you find a patient who is having both the limbs extended. Then you can easily say to your students that the patient is having a lesion in the brain stem or below the brain stem, maybe in your upper cervical spine. If in case, if the patient is having a decorticate rigidity, you can say the patient is having a cortical lesion or a subcortical lesion where the cortex element is taken out of the proportion. Okay. Next is your lower motor neuron lesions. There may be some history of injury in most of the lower motor neuron lesions, but it has a very variety of, in case of injury only, traumatic cause for lower motor neuron lesion is maximum compared to non-traumatic lesions like your peripheral neuropathies, your sensory neuropathies are all not that much common. You said, Niraimati ma'am has said, you said rigidity is specific for brainstem, basal ganglia. Then why loss of cortex control is not termed decorticate spasticity? Why it is called as decorticate rigidity? Yes, this is a very good question. So we should know about what is the difference between a spasticity and a rigidity. Okay, I'll use a whiteboard to explain you that. One second. Okay, so now we will see what is spasticity and what is rigidity. What is the difference between them? You should know. So I told you that your spinal cord is there, and you have your anterior horn cells and the posterior horn cells in this, and this is maintaining the stretch, deflex, and all those blah blah blahs I told you. And um, you have alpha motor neurons, and I said you have gamma motor neurons. So alpha motor neuron is responsible for movements, and gamma motor neuron is responsible for maintenance of the tone. I told you this. So now I will tell you how it is maintained. You have the cerebral cortex. Okay, here cerebral cortex. You have basal ganglia. Okay, and you have RAS in between, reticular activating system. So the reticular activating system constantly send information to the gamma motor neuron. What is that? It is the gamma motor neuron which is getting a constant stimulation from the your RAS. So what happens as a result of that? You have a gamma motor neuron discharge. This gamma motor neuron discharge directly goes to the intrafusal muscle fibers of the muscle spindle, and the muscle spindle sends information indirectly again to the posterior horn cells, and that information comes to the anterior horn cells and comes to the extrafusal muscle fibers, and there is always a tension. Am I confusing? I told you gamma motor neurons and alpha motor neurons are there. Alpha motor neurons are going to stimulate the extrafusal muscle fibers, and gamma motor neurons are going to stimulate the intrafusal muscle fibers. Okay, so so the RAS has a constant input towards the gamma motor neuron, which maintains the muscle tone. That is why we say even when there is a resting state also, your muscle has some tone. Okay, the spinal cord, I'll keep it as spinal cord, and invariably the tone of the muscle. Now the cerebral cortex have a positive influence on the tone. You have to remember this, whereas the basal ganglia has a negative influence on the tone. The basal ganglia cannot influence the reticular activating system directly, so it influences the cerebral cortex. What it does, it diminishes it influences the it reduces the activity of the cerebral cortex. Cerebral cortex communicates to the RAS. So RAS is positive to the tone. What it is positive to the tone. Now just remember this. Again, I'll tell you, when the cerebral cortex is activated, that is, it sends information, it sends excitatory information to the RAS, and RAS sends excitatory information to the spinal cord, as a result of which your tone is going to be increased. Am I right or not? In case if your basal ganglia is sending information, it sends inhibitory influence to the cerebral cortex, and the the discharge to the RAS is going to be diminished again, and RAS is also going to diminish the information it is giving to the spinal cord, and the tone is going to be diminished invariably. So what happens if there is no basal ganglia? If there is no basal ganglia, the cerebral cortex will start giving information continuously to the RAS in a very excitatory mechanism, excitatory manner, and that causes rigidity. Okay, that causes rigidity. The basal ganglia is not there to control the inhibitory influence, so it causes rigidity. What causes spasticity then? If both basal ganglia and the cerebral cortex both are not there, what happens? The RAS is always sending an information to the spinal cord, which is excitatory. That is the only information that is coming down. The upper centers do not have any role to play in the tone now. It is all the RAS positive discharge that comes to the tone. So we also saw that the RAS is influenced where the reticular activating system, we saw it receives information from the sensory input mechanism. Whenever there is a sensory information going from down to upwards to the RAS can be activated. So what happens to the tone? Tone can also be increased. That is why when you do a fast passive movements, suddenly your tone increases. So this name velocity dependent component is given to the tone because of the RAS activity. The RAS can be stimulated by some any movements or sensory information. Also yawning, sneezing, pinching, all these sensory inputs, which are high velocity sensory inputs, which are going to the given from the periphery, goes to the RAS to the brain. So they can stimulate the RAS. Once the RAS is stimulated, its positive influence on the tone is also increased, and the patient is showing a increased tone. But in case of a rigidity, you know that the basal ganglia is only affected, your higher centers are still there, that is your cerebral cortex is still there, so it can control the RAS. So any sensory input you are giving to the RAS cannot alter your tone. Please understand, because this is a very complex control. The physiology, I think you cannot learn very deeply when you are going into it. Takes a lot of time for you to understand. So rigidity is not a velocity dependent component, whereas spasticity is a velocity dependent component, only because in spasticity your both cerebral cortex as well as your basal ganglia's influence on the RAS is lost. It is only the RAS that is discharging. In case of a Parkinsonism or in case of a basal ganglia disorder, the problem only is with the basal ganglia. It is not sending any inhibitory influence to the cerebral cortex, and the cerebral cortex purely maintains the activity. Okay, that is why in case of a Parkinsonism, you ask a patient to do a movement, he will do the movement, he will do it very slowly. He will have voluntary control, but that voluntary control will not be properly timed because the basal ganglia is not there. So there the rigidity is not dependent on the velocity, only the spasticity is velocity dependent component. Now the question that madam asked was why it is called as decorticate rigidity and why it is not called as spasticity. So to explain that, we have to say spasticity affects only the flexor muscles of the body, whereas not flexor muscles, it affects only the agonist of the body. Antagonist is not affected. It is spasticity. Rigidity means it affects both the agonist as well as the antagonist. That is why most of the time when you are assessing tone for a basal ganglia lesion, or Parkinsonism, you won't get tone because the reciprocal inhibition is lost. Your spasticity is there in both the agonist and the antagonist, and it will not allow the movements to take place in case of a reflex assessment. So what I'm trying to say is, in both decorticate and decerebrate rigidity, the basal ganglia is also the basal ganglia's influence on the nervous system is also lost, because the basal ganglia cannot influence the spinal cord directly. It can influence through the cerebral cortex. Got it? So both the time we get rigidity, both the time the basal ganglia is affected. Cannot influence the spinal cord. So we use this word rigidity. Got it? So both the agonist and antagonist are affected here in the thing, and the patient is in a most of the time the patient shows this particular type of posturing of the upper limb. Thank you, ma'am. Thank you so much. So when you see this, that is why we always say that mere stretching or mere positioning of your hand cannot solve spasticity or rigidity, because the problem is more higher centers. So when physiotherapists try to stretch a spastic muscle and say that after stretching the muscle is going to lose its spasticity, that is when we feel astonished to know that people like Bobath, Roods have educated stretching as a one form of reducing spasticity. All those inhibitory techniques which were taught are all failed, because spasticity is not merely associated with the muscle spindles or the extrafusal muscle fibers. It is associated with the discharge from your higher centers. If only your higher centers takes up the control, the spasticity will come down. Otherwise, it will not come down. Fine. Thank you so much for giving me an opportunity to explain to you. Okay. Now coming to the lower motor neuron lesions, there are a lot of causes for lower motor neuron lesions. You can't say one. It may be an infection or a mechanical cause or an injury or something like that. But classically, how it presents, it will definitely present with a hyporeflexia. Okay. Why hypotonia, hyporeflexia? You see that in a reflex arc, which is more important for the reflex arc, the sensory nerve fiber and the nerve fiber. Both of them are very essential. Okay, so both of them are very essential. If the sensory nerve fibers are affected, then also the information of tapping the tendon will not reach the spinal cord. And if the motor nerve fibers are affected, then also the reflexes will not be conveyed to the extrafusal muscle fibers. So both sensory as well as motor neuropathies can cause a reduced in tone and reflex. Next is the lack of muscle power will be lost. Okay, and sensory deficits based upon whether the peripheral nerve is a peripheral nerve involved is a sensory nerve or a whether it is a motor nerve, or in sensory nerve whether it is a C fiber or a delta fiber, based upon which the sensory nerve fibers sensory involvement can be recognized. Muscle wasting will be there. Because contractures and muscle wasting are very common here, because the muscle fibers are going to be less, and the weakness is going to introduce a muscle imbalance, where, for example, if your biceps is strong and your triceps is weak, your positioning of the body part is going to be like this, where your biceps can be triceps, which is weak, can lose muscle, that is wasting. Okay, the primary muscle goes for wasting, and the contralateral muscle, that is the antagonist to that muscle, is going to go for contracture. You don't see much of muscle wasting in case of a stroke patient, because in stroke patient the tone is going to be high. The spasticity itself is a contracted state of a muscle. So when the muscle is in a contracted state, definitely it will not go for wasting. Very rarely you see wasting in the hand muscles of the stroke patients, but often you don't see much of wasting in stroke patients. You also, in case of this sort of a symptom, you also see a restrictive lung disease. Uh, Rarely balance will be affected in case if there is a proximal involvement of the peripheral nerve is there. Peripheral nerves that supplying to the proximal muscles, if they are involved, then definitely there will be a balance. But most often, not like the upper motor neuron lesion, you will not have a balance disorder. Gait abnormality based upon which nerve is involved. If the common peroneal nerve is involved, you will have a high stepping gait. Whereas if there is an involvement to the gluteal nerve, then you will have a waddling gait or a back lurching gait. Functional deficit based on the limb involved. If one limb is involved, the functional limitation will be less. Whereas if two lower limbs are involved, bilaterally symmetrical neuropathies, then the function will be even more involved. But the functional loss of a lower motor neuron 9 out of 10 times may not be as severe as that of a upper motor neuron lesion. Okay, so not wasting much time into this, you should know what is a dermatome and myotome for differential diagnosis. That we will see now. Not now, we will see later on. Okay, fine. Movement disorders, I have explained to you here. The problem will be aging. Most of the time, the problem will be aging or any ischemic or a hemorrhagic problem. A significant movement problem, quality of movement is the one which is a problem, whereas there is no problem with the muscle power or the voluntary control as such. It would not be a problem. Here, the problem is with the movement quality. Most of the time hypertonicity will be there, particularly rigidity type, but in case of a cerebellar lesion you will have hypotonicity. I told you why, because the cerebellum has a positive influence on the tone. The reflexes in case of Parkinsonism may be absent or normal. In case of a cerebellar lesion, the reflexes can be diminished. Improper movement time and reaction time is a very important time. So when I say movement time, that means how much of time that is taken to execute one particular task is movement time. From the moment instruction is given, how long it takes for the patient to initiate the task is called as the reaction time. I ask a patient, now you touch your nose. When he starts initiating his hand to touch his nose, that is called as the reaction time. Always remember, movement time and reaction time will not be diminished, it will be increased. Most of the time, even knowing the process, many students used to make the mistake. When I ask them in the examination, what happened to the movement time and reaction time in Parkinson's? Sir, they are all diminished. That should not be the answer. They are increased. Okay. Lack of coordination in case of cerebellar disorder, and occasional sensory problems. It is not very common. It is very rare sensory problems in case of a movement disorder. Tremors will be there. You have two types of tremors. One is an intentional tremor and another one is a resting tremor. It's a very important differential diagnosis in case of this thing. So what is resting tremor? When the patient is having his hand rested, that time he will have small tremor like this. But at the same time, when the patient is moving his arm, this tremor is going to disappear. Okay, that is called as a resting tremor. This happens in case of a Parkinsonism. So don't write that I am going to treat the resting tremor in any of your management, because this resting tremor is not going to affect your functional activities. Simply, it disappears when you start moving. And there are studies which states that this resting tremor keeps the muscle in a so it helps in patients who has tremor have a good quality of movement compared to patients who do not have tremor. That is a study. Whereas the next thing is intentional tremor. What is intentional tremor? In case of a cerebellar lesion, when resting, the patient will not have any tremor, but once he's he will have all sort of tremors in holding on to object, and the tremor quantity of the tremor can be high in case of a great lesion of the cerebellum. So here the problem happens when the patient is functioning. The functional task can be affected. So you really have to interfere with the tremor, and you have to reduce the amount of tremor in case of a cerebellar disorder. That is called as a intentional tremor. So resting tremor and intentional tremor will tell you whether the patient is having basal ganglia problem or the problem is with the cerebellum. Next is the patients may have some speech disorders which are not like the upper motor neuron lesion. You will have articulation problem. That is when the cerebellum is involved, the patient will have dysarthria where the content of speech will be good, but the articulation, that is how he combines words together and spill them out, that will be the problem. In case of Parkinsonism, you will have a problem of difficulty in speaking in different modulations. That is monotonous pattern. So those type of speech disorders can be there. Cognitive will be present in terms of memory. You have memory. We saw that there is a good amount of memory storage for the basal ganglia for movement memory. So there will be a problem with memory. In case of which it results in some cognitive problem. Here also restrictive type of lung disease can be there because of the rigidity of the respiratory muscles, balance disorder, gait, fascinating gait, or ataxic gait can be present, and functional loss will be more, and it will be progressive, and it is going to be tough for the therapist to manage. Got it? The last is the myopathic or the neuromuscular junction disorders. So not much related to the nervous system, but I told you it is the interface that is going to be affected. Most often this is going to be gradual onset. History of infection may be there in case of any neuromuscular junction disorders. Autoimmune diseases are very common, and genetic conditions are very common here. Okay, most of them are progressively deteriorating, and they are going to have a very poor prognosis. What are the classical findings there? Hypotonicity will be there, hyporeflexia will be there. Why hypotonicity, hyporeflexia? Because I told you for a good reflex to maintain, you need a good end organ, that is your muscle or the neuromuscular junction. Here both of them are affected, so the reflex arc is going to be distorted. So they will definitely have a hyporeflexia and hypotonia. Severe lack of muscle power will be there. So when I say severe lack of muscle power, you should be very cautious in giving your movements and repetitions of movements. You should not force too much of exercise to them. We can tell the other three group of people that more you exercise, more you will be fine. But here in the myopathies and neuromuscular junction disorders, know your limit, how much repetitions you have to do, because your muscle will become completely fatigued and it will lose its muscle fibers if you are going to work out too much on these patients. There will definitely be no sensory involvement. Muscle wasting and contractures will be too much compared to lower motor neuron lesions, because there some nerve fiber discharge can be there in case of neuropraxia or axonatomosis. But in case of a neurotomosis, there won't be any discharge to the muscle. But neurotomosis is very rare compared to axonatomosis and neuropraxia. But here, the neuromuscular junction disorders and the myopathies, the wasting is going to be more, and it is going to be progressive. Okay, the patient will classically say that last year he was able to walk, sir, but this year he is becoming more weak and he is not able to get up also. He's simply standing and he's not walking. So that's sort of a history. Progressive weakness will be there. Restrictive lung disease can be there because of the muscle paralysis. Balance will be a major issue if the trunk and lower limbs are involved. But in case if muscular dystrophy of the dystonic type, where only the neck is affected, the balance may not be affected that much compared to the other, like your Duchenne's or Becker's muscular dystrophy. Gait abnormality will be there. Most probably the waddling gait is common here. And also neuromuscular junction disorders affects the most proximal muscles. So limb proximal muscles are affected. So gait abnormalities and functional deficits will be very progressive in nature. So with this, we conclude this. We have classified. What we have done is, now we have seen all the basic anatomy and physiology, and we have classified the neurological disorders. Now, quickly what we are going to do is we are going to go for a neurological assessment. Um, a proper neurological assessment, how to do. Within 15 minutes, we'll have a break. Okay, now we will see up to the subjective examination and we'll go to the. Now, this is what I told you in assessment part, we have a problem. We don't do this assessment for a reason. We do it simply because your teacher will ask you to do, or the documentation of the patient needs an assessment. We know that the patient is a Parkinson's patient and then only we do the assessment. But how it should be, you should take subjective assessment very seriously. You should ask enough questions to the patient. This subjective assessment should lead you to a hypothesis. Okay, the patient is having upper motor neuron lesion, well and good, but where is the location of lesion? Because where is the location of the lesion will tell you how far the patient is going to progress. I told you that the presence of neuroglial cells can bring about a better prognosis in the patients if the problem is in the brain, particularly the cortex. The pure cortical problems resolve better. The subcortical problems resolve slightly better. The brainstem little bit less, spinal cord even more less, and the peripheral nerve system completely bad. So when I tell you that the hypothesis is very important because it is going to tell where is the location of lesion. Tentatively, you are going to ask the patient all subjective history and you're going to frame a hypothesis, and this hypothesis you are going to test using your objective assessment. For example, if you are doing a subjective examination and you come to know that the patient may have upper motor neuron lesion, okay, I'll repeat the last sentence. So what I was trying to say is, from the subjective examination, you should come to a tentative idea what might be the hypothesis. With the hypothesis, it's a tentative idea, it is an imaginary statement. You are going to confirm this hypothesis using your objective assessment. Got it? So it is like a police inspector goes and do investigation by seeking information from all the victims, and he will come to idea that this might be a problem of this, and then he will go and find evidences and collect evidences and document them and file that on the court. So it's more or less like that. Or even you can take a research process. You have a research problem, you collect information about the research problem, you have a hypothesis. That hypothesis you will do a research to know whether the hypothesis is true or wrong. This is nothing but a hypothesis driven assessment process. Here you are taking a lot of information from the subject. You are taking a lot of information based upon which you come to an idea, maybe his cerebellum is involved. Okay, so once you know that, once you think that his cerebellum is involved, you are going to confirm that the cerebellar lesion is the one which is causing all the trouble by means of his objective assessment. And subsequently, once the objective assessment is over, you are going to confirm it is a cerebellar lesion, and that is called as the physical diagnosis. Okay, this is how your assessment should be. Most often what happens, subjective assessment stands separately, objective assessment stands separately, and the treatment will be something else. Most often it is passive movements. Okay, so please don't do that. That is what I am explaining here. So the physical diagnosis, after the physical diagnosis, you will come to know what are all the problem. If you don't identify these problem list from your assessment, then your assessment is completely waste. Okay, once you assess the problem list, you are going to pace your goals, and once you pace your goals, you are going to go for the treatment plan. So very importantly, the order of priority of the treatment should come from the problem list. Which is the major problem for a physiotherapist here? That should be first, second, third. For example, if I have 3 problems, all the 3 problems should be coming in the goals. I should mention all the problems in the goals also, because if I have some problem and if I don't attest the problem in my goals, then the problem is not a big deal at all. For example, if I have weakness of the upper limb as my first problem, okay, and learning as a second problem, the patient do not have a proper learning of movements, And the third problem is balance. Then I have to devise something to attest in the goals for the three things. And if I set that as a goal, I should attest them in the treatment. So what I'm trying to say is you should have a flow of information from the problem list to the goals to the treatment. Okay. Nirmati ma'am has asked one question. Sir, you were saying about chances of recovery based on the lesion. Can you please repeat it? Okay. Um, I told you that the recovery chances are more in the cerebral cortex and the subcortex because you have abundant neuroglial cells. You are seeing that astrocytes, oligodendrocytes, all those things there. Okay, because there is support cells for the neurons, the recovery of the neuron is also possible and it is going to be good. More cephalic the problem, more the recovery. More caudal the problem, the poorer the less faster and the spinal cord do not recover as much as a brainstem. The peripheral nerves do not recover as good as the spinal cord. Though there is some sort of a regeneration that is possible in the peripheral nerves, but the recovery of a peripheral nerve cannot be compared with that of a cerebrum. Okay, so that is what I am trying to say. The location of the lesion is very important. For example, if the location of the lesion is in the corona radiata, the corona radiata where you have a wide, the nerve fibers are widely placed, there the recovery can be much better because even though there is a big lesion, the amount of involvement will be less. But in case, if you see if the lesion is in the capsular region, internal capsule, where all the nerve fibers are completely packed, a small lesion can also cause a big problem in the stroke patients. So how to identify that? If a patient is coming to you with complete loss of upper limb and lower limb, both of them are completely affected, motor is affected, sensory is affected, but the patient is having a very bad functional deficit, then definitely the internal capsule will be affected. I'll tell you on a average basis, if you see 95% of the patients who have a big stroke, that is, who have a problem in sensory, motor, and if it involves the upper limb and lower limb, okay, so this is we call it as a grand stroke. So if there is a grand stroke, fully established pattern of stroke, definitely his internal capsule will be affected. If you see monoparesis in a patient with CVA, you can very well say that 90% of the time the infarction is going to be in the corona radiata, because corona radiata is a widely placed nerve fibers are there in that. So likewise, if you have your respiratory and cardiovascular problems associated, you can say that it is the brainstem that is affected because you have your respiratory centers and the circulatory centers in your brainstem. Okay, yeah, thank you. So now the physical diagnosis, problem list, goals and treatment should be in a sequence. So when you are appearing for an exam or when you are writing an assessment, don't have problem list, 10 problem list and goals attesting only 5 of the problem and treatment attesting only 3 of the problem. That is how most of my students do. I find them mistake in this place. Why you are not attesting this problem, I'll ask. So have a orderly sequence. Okay, nice. Now, the subjective assessment, you should have chief complaints. How you should have this chief complaints, you should put open-ended questions to the patient. Like, do you have pain? That is a closed-ended question. The patient will say yes. So you cannot extract more information from the patient. You should ask, what is your problem? What do you expect from this treatment? What do you think you are suffering with? All these things are open-ended questions. Okay. So next is, you should have documentation of the chief complaint should be in a hierarchical manner. If a patient says, sir, my problem is I am not able to lift my hand up to reach out to objects, that should be our first problem list. Then they will patient say, I have pain when I am lifting up. Okay, so then pain becomes second. And then the patient will say, you have any other complaints? If you ask, sir, because of this, I am not able to hold objects and I am not able to lift heavy weights, then that should be the third chief complaint. So it is philosophical, which is your most major problem the patient will come out with that particular problem first. So order of recording is very important, and that order should be set by the patient, not the therapist. Next, it should be in patient language. Don't record any technical terminology in the chief complaints. If the patient says, I'm not able to put my hand and reach the object, you should not document lack of elbow, shoulder flexion and elbow extension and elevation activities. So that should not be the thing. Chief complaint should be in the patient's language. Whatever he says, you have to reproduce here. Okay. If the patient says that I am having a sensation of burning all over my upper limb, you have to document that. Okay. So you should not say a vascular pattern of pain is present in the upper limb. Got it? So fourth important thing is duration should be mentioned. Any chief complaint should have the duration. Sir, I am not able to lift my hand and touch objects on the shelf for nearly 4 or 5 weeks. That's how people will normally say. So duration you should mention, because all these things give you a very good idea about what the patient is suffering with. Next, the subjective examination. Very importantly, the history taking. This is a very important thing if you are working in a neurological area in a hospital. You should not think all the patients coming to you are having neurological problem. More than this, you should know that all the patients coming with some complaints are patients. They may not be a patient also. They'll be coming with some psychological issues, which like sort of a pain. They think that there is having some pain, but there may not be any pain at all biologically. And moreover, don't think all patients as neurological. There may be some musculoskeletal problem also in that patient. This is a disclaimer. This was said by John Patton, whose book is a very significant contribution in the differential diagnosis of neurological conditions. Next is subjective assessment. First, very important thing is don't ask the patient immediately he enters into the clinic. Ask him, give some time to settle down. Okay, discuss how I develop relationship with patients. I will ask them, what is your name? They say, my name is Kumaran. So from where you're coming, Kumaran? He will say, I'm coming from Chennai. Oh, great. My native is Chennai. I live in Chennai for nearly 20 years. So I relate him with that. If he says, no, I belong to Tanjavur. No, I was born in Tanjavur. Very good. Where you are coming from, Tanjavur? Likewise, in Tamil Nadu, if he says whatever place, I will relate him with my some or the other activity. If he says I am coming from Coimbatore, I'll say, hey, I studied in Salem and Coimbatore only. Where you are coming from? So that bonding and the nativity you develop with them will help him in coming out with more informations compared to just immediately after he coming in, you are asking him question, means that is going to be not develop that particular rapport between you and him. Okay, and then avoid repeatedly looking at the clock or any other areas diverting when the patient is saying. I have seen many therapists will the patient will be looking there, they'll be looking into their mobile. Nowadays, that's a very important thing people do with mobile. You keep on telling I look into my mobile, then the patient will not come out with the information. So you have to maintain the eye contact with the patient. That is very essential. If you want to confirm with the information of the patient, you have to use the third party, that is his caretaker. But make sure that you don't land up in trouble where they arguing on certain thing and you will just become a referee in that. Okay, that also happens. Sometimes direct questions will help you. I mean to say direct questions in the sense the patient will say, from yesterday night I have severe lack of sensation in my thighs and my lower limb. Bilaterally, I'm having this problem. If you suspect the patient to have any problem during his sexual intercourse, or if you feel like he's having a sensory neuropathy, particularly diabetic sensory neuropathy, restrict yourself in asking him question directly. Do you have any problem in your sexual life? If you have any problem in the erection problems, you should directly ask questions. There you can use the closed-ended questions. Fine, because most often, because of the social stigma and the resistance, patients will not come out with the real truth. So you have to ask them. Next is be specific with the symptoms. For example, if the patient says, sir, this weakness gradually came, sir. Gradually means what? Define it, whether it is days, weeks, or month. Even if it is developing over a period of month, also they will say gradual. If it is year, also they will say gradual. So you should know what is number of days. So if it had developed within a given number of days, you can say it's a vascular problem. If it is developing over a period of months, you can say it is a tumor. If it is developing over years, you can say it can be myopathy or any neuropathy. So depending upon the duration, you can come to some conclusion about the differential diagnosis. There are some other direct questions you can ask the patient about the pain. If the pain has, remember that in assessment of neurological conditions, you should have a pain history completely charted like a musculoskeletal problem in case the patient complains of pain. So previous medical history, if you have any specific details, if you want to ask, sir, are you taking eptoin tablet? Are you taking Sindopa tablet? When you are taking, how long you have been taking? These direct questions you may think that physiotherapists may not need these details and they may not take. And previous occupational history is very essential because that will give you a clear idea about what was the problem of the patient. The family history will give you clear idea about any genetic disorders which we saw in neuromuscular disease. So first thing, very importantly, after listening to the history, what you should come to a conclusion is determine whether the patient is having a specific set of symptoms which classically defines a condition. For example, if the patient says, I have paucity in movement, I'm not able to shout louder, I'm not able to walk faster, slowly my movements are coming down. Classically, you can see that Parkinsonism, and you can have one single hypothesis that it is a Parkinsonism. Your hypothesis is very simple and direct, so no problem. But in case if you have the patient coming out with numerous issues, symptoms, the problems are, the patient says, I'm having unable to lift this hand, I have pain here, I have nocturnal urea, all these things. If the patient is coming up, then your hypothesis is going to be very tough for you. And in my experience, if the patient is very precise with their chief complaints, then they have a major problem. But when the patient is not precise with their chief complaints and they are just spraying out information, then the problem may not be a big problem. Okay, so this is out of my experience I am saying, because patients who are coming with CVA will have one or two chief complaints only, but they'll have major functional limitations. But patients who are coming with some neurological pain related problems will have many complaints, but their problem may not be actually that big. So that is my experience. Next is you have to identify a specific pattern in all the chief complaints the patient is giving. So the second scenario becomes very tough. Okay, and now once you form a hypothesis, you can have one or more hypotheses. It should be in an order, very importantly, because the most I suspect this patient to be a Parkinson patient. Okay, I also suspect this patient to have a supranuclear palsy because he's complaining of a sudden onset of all these symptoms. Supranuclear palsy, mind you, is more or less like Parkinsonism, but it is a vascular disorder. Here, dopamine is not a problem. It is a vascular disorder which affects a superior nucleus, which results in classical symptoms of Parkinsonism. Okay, but one or two things will be missing, but this is also a condition. So I suspect this patient to be 70% Parkinson. So first hypothesis is Parkinson, but he may be a supranuclear palsy also. So PSP will be second. So that order you should maintain. Should be at impairment level or activity level. That is the very important thing. Impairment level means some anatomical structure should be involved, anatomical function should be involved. So more you go specific, you can go with the impairment level. Very rarely you can give activity level hypothesis. So when I say impairment, if my axillary nerve is affected, that is my impairment, because of which the biceps, the deltoid goes for weakness, that is impairment. Because of that, what I'm not able to do, I'm not able to elevate my hand, that is activity. Because I'm not able to lift my hand, what I'm not able to do in my day-to-day activities, I'm not able to pluck flowers, I'm not able to keep objects on the top, I'm not able to do my functional, I'm not able to comb my hair. All these things are called as participation restriction. So your hypothesis should be mostly impairment level, and it can be activity level. Okay, this is what we the ICF classification. Now we will take 5 minutes break and we will assemble to see what are the objective assessments. Any doubts so far? We have another 1 hour and 45 minutes very fruitfully. We can utilize them. 5 minutes of break. What is the difference between activity limitation and participation? So the activity limitation is any activity like a sit to stand, or elevation of hand upwards, or a balance activity, or a gait activity. All those things are activity, because of which what is a social problem the patient is facing. If I'm not able to walk, I won't be able to go to the temple, I won't be able to go to the railway station. So all those things are participation limitation, that is restriction in participation. Participation means participating familially, participating socially, participating occupationally. So what are all the problems we are facing? That is called as participation restriction. As a physiotherapist, you give intervention to the patient impairments, but how often you make sure that you reduce their, you improve their activity? That is also okay, but how often you concentrate on increasing this participation restriction? That is, we miss out on that. We don't ask whether the patient is able to walk to a nearby post office, or we don't guide them to walk in the society. So the ICF classification is very significant compared to all the negative words which were used before, like impairment, disability, handicapped. All those things were negative statements, but two negative statements, the impact, disability and handicap, have been replaced by somewhat moderate words, like positive words, like limitation of activity and participation restriction. Like how we say people as differently abled compared to disabled. So that is how it is. Fine. Now we'll continue with our objective assessment. You know that objective assessment will have on observation, on palpation, on examination. On observation, you will have, I don't want to spend more time on this, because you know all these things, built attitude of the limb, alertness, external appliances, pressure source, all these things you know. I don't have much to tell you in palpation. In neurological examination, we don't palpate much, because palpatory assessment are most elusive assessment. It will give you a lot of illusionary information. Many patients, many physiotherapists will tell, I palpated the muscle tone, it was weak. That will mislead you. So palpatory assessment in neurological assessment or not that significant. In case if you have some edema or something like that, you can know whether it is a pitting or non-pitting edema, but that also comes in examination. It not as a purely palpatory examination. Next is the higher mental functions. The first on examination, you should see the higher mental function. So when I say higher mental function, 5 important things are there: consciousness, comprehension, orientation, attention, and memory. Very importantly, these things are there. In consciousness, we can say whether the patient is in stupor, or he's in coma, or he's in confusion. Based upon the GCS scores, you can say whether he is conscious. Next is comprehension, is whether he's able to understand whatever I am saying. Okay, and understand to inputs like auditory input, or any visual inputs given to them, if they're able to understand and perceive that language, is called as comprehension. Orientation is whether he's able to communicate back, whether he's oriented to place, person, thing or not. Those things you know very well. Attention, in attention, is he able to give concentration to one particular sensory input for a given span of time? That is called as attention and attention span. This we are assessing simply because to know how alert he is, and to what extent you can give him some intervention like exercises. If the patient is having a reduced attention span, like he has only for 10 minutes, your physiotherapy session cannot go beyond 10 minutes very effectively. You should know what are all the techniques to grab his attention back. So that is very essential. Memory is also a very important thing. It will also give you an idea about what are the centers that are affected, on which memory is affected. And it will also give you an information about how complex exercises you can give, because how the patient will retain those informations. So all those things are going to be known. So when I say assessment, it is not only to know what is the patient's condition. Not most often people think to find out whether it is a Parkinson's or a Guillain-Barré syndrome or a peripheral nerve disease, but it is actually done to know what are all the facetal problems the patient is having, wide variety of problems the patient is having. So based upon which we can frame our treatment. So the higher mental functions, which is most ignored part of physiotherapy management, is a very significant, has a significant influence on the management. Okay. And apart from that, you have the intellectual capacity, decision making, calculation, then the reasoning part. All those things are separate. They are also higher mental function. Next, what you have to assess is very importantly the perceptual deficits. If the patient is having apraxias, agnosias, aphasias, all those things, if the patient is having any perceptual disorders, which can localize the condition. For example, if the patient is having a Broca's aphasia, you can say that the patient is able to comprehend better, but he will not be able to express his ideas. That is called as expression aphasia, where you can say the lesion is in the frontal lobe, and you can say that the Broca's area is what is affected. In case if the patient is able to articulate things, but he's not able to understand things, then you can say the problem is in the Wernicke's area, where it is called as receptive aphasia. So based upon that also you can localize the lesion. But very importantly, you will know what treatment should be given and administered to the patient in case if the patient is having apraxia, which is nothing but difficulty in performing a skilled activity, which he has already learned, which he was doing before the stroke, but after that he won't be able to do the skilled activity. Simply, for example, the patient doesn't know how to put on his dress. Okay, there are various types of apraxias, but not in the scope of the presentation. Next is the cranial nerve examination. Is a very important examination to localize the lesion, whether it is present in the brainstem or it is present in the brain or it is present below the brainstem. Because your cranial nerves, first two cranial nerves, optic and olfactory, olfactory and optic, arises from the brain. If there is any problem in these two cranial nerves, you can say that the problem is in the brain. In case if the patient is having any problem in the facial nerve, you can very well say the problem is in the pons. If it is on the same side, you can say it is on the pons. If it is on the opposite side, you can very well say that the lesion is just above the pons. And the examination of the cranial nerve is very essential in localizing the level of lesion. And also, very importantly, if the patient is having difficulty in swallowing, where there is a glossopharyngeal nerve involved, more than the motor rehabilitation of the limbs and the trunk, here the importance of re-educating the dysphagia is going to be very important, because if the patient is not able to swallow and drink, he's going to go for dehydration, he's going to go for malnutrition, and that is going to invariably affect the patient's motor performance very badly compared to the stroke as such. So you have to concentrate on that. Prioritizing your treatment can be given a clear idea when you are doing a cranial nerve examination. So, Next is the motor examination, where you're going to do a reflex assessment. The deep tendon reflex assessment is going to give you a clear idea about where is the level of lesion. Okay, if the reflex is diminished or less, you can very well say that the problem is lower motor neuron. In case if the reflexes are diminished but other symptoms are suspecting a upper motor neuron lesion, you can very well say that because of the reflex is lost, then the patient is in case of a cerebral shock, or it is a pure cortical lesion. If the reflexes are high, then you can very well make sure that it is a upper motor neuron lesion, not a problem at all. In case of a superficial reflex, which is different from the deep tendon reflex, because superficial reflex are polysynaptic reflexes, whereas deep tendon reflex is otherwise called as a monosynaptic reflex. There is only one synapse that is happening in the deep tendon reflex, where there is a synapse between the sensory nerve fiber and the motor nerve fiber. Whereas in the superficial reflexes like your Babinski sign, your abdominal reflex, your cremastic reflex, there you have various synapses. Okay, now I'll put you one direct question to you. Why you get a extensor plantar response when you are doing a Babinski sign? We say that Babinski sign is positive only when there is an extensor plantar response. Why we say so? Anybody? Why the toe is going for extension? Why it is not going for flexion in case of upper motor neuron lesion, but in case of a normal person it goes for flexion? Why is it so? Any answers? All these days you have been doing extensor plantar response, this Babinski sign. All your teachers might have taught you that there will be extensor response to the extensor hallux, or the all the fanning of the fingers and extension of the great toe will happen. But why that happens? No idea? Okay. Yes, somebody is typing. Because pyramidal system is damaged and extrapyramidal take over. Okay. So what happens because of that? That's a good answer. That's a correct answer. So we say the extensor plantar response positive when there is a pyramidal involvement. So I told you that pyramidal system always have a influence on the flexor tones of the entire body, irrespective of the upper limb or lower limb. So when you give a sensory input from the sole, that is most sensitive part of the sole, this stimulates the somatosensory area, and in turn the sensory area responds to the sense information to the motor cortex, and from the motor cortex you send information down to the extrafusal muscle fibers by means of the pyramidal tract. If this complete system is intact, then only you will get a normal flexion response because pyramidal tract is dominating the flexors of the muscles. But in case if the pyramidal system is lost, if the pyramidal system is not functioning, this information goes to the cerebral cortex. So the cerebral cortex invariably will send information to the reticular activating system, and the reticular activating system will send information to the extensors of the lower limb, and it will go for a fanning of fingers. Okay, so now we are testing the integrity of the pyramidal system. Why we are not doing the scratching on the upper limb? Why normally we do plantar response and grasp response in children, but we don't do this Babinski sign in the upper limb, because your ribrospinal tract is influencing the flexors of the upper limb, where you cannot distinguish whether it is a response from the ribrospinal or it is from the pyramidal tract. That is why we do it on the lower extremity. Got it? So in there is an extensor plantar response, you can make sure that there is a pyramidal involvement. In abdominal reflex, what we do, abdominal reflex, we test the integrity of the, whether to see whether it is a lower motor neuron lesion or upper motor neuron lesion. If your umbilicus is like this, it is at the level of T10. Okay. So when I do a scratching in this manner, I am testing this right side. Okay. This is right side. I am testing T9 and T8, two dermatomal levels above the umbilicus. When I scratch this way, I am testing the left side at T9 and T8. When I do the one on the lower quadrant, I am testing T11 and T12. And here it is on the left side, T10 and T12, T11 and T12. So if the reflexes are absent, then you can make sure that it is an upper motor neuron lesion. So this is not a much authentic reflex because there are studies which states that only 80% of the people have a normal abdominal reflex. And even in that 80% of the people, the reflex is diminished or not visible in case of people who have a big tummy, particularly in case of a male patients who have a lot of tufts of hair. And people who, there is one more very significant study, people who lie down on their tummy also have a diminished reflexes. So it is not a much with which you can come to a conclusion that it's an upper motor neuron lesion. So most often or not, this abdominal reflexes are not documented in the investigation reports of patients. Only it is the extensor plantar response, that is your Babinski sign, that is assessed. So you can also assess the tone, you can also assess the voluntary control, you can assess the muscle power, and everything comes in the tone, sorry, motor system. So this voluntary control assessment is very useful when you are doing assessment for a stroke patients. Many people, I had a lot of argument with people who say functional rehabilitation and who are pioneers in the field of stroke rehabilitation, who go for muscle power assessment for stroke patients. What I argue is, in presence of spasticity, it is very difficult to assess a muscle power of an individual muscle because you will not have an individual muscle performing. Most often you feel like whenever you ask the patient to do a wrist extension, the patient will do shoulder elevation and elbow flexion, and then he will try to do wrist flexion, and actually he will not be able to produce. So there is synergy which is existing. In the presence of synergy, it is very tough for you to assess the muscle power. You can assess muscle power if you have enough time to do that, but in a clinical setup, it is always better to go with a voluntary control assessment. So when I say voluntary control assessment, you should document whether the patient is able to initiate, sustain, and terminate the movement. So initiation, you need concentric contraction. For sustaining a movement, you need a isometric contraction. And for a proper termination of a movement, you need eccentric contraction. So you can test the three muscle activity types of muscle contraction by means of asking the patient to initiate, sustain, and terminate the movement. If you want to go for some more advanced things, you can ask the patient to move in diagonal patterns reciprocally, like supination and pronation continuously, opposite direction movements, and whether the patient is able to move against resistance, that is not a resistance given by the therapist, but a resistance which is offered in terms of an object or against the gravity or something like that. Because when it comes to stroke rehabilitation, the question of strengthening is less prioritized compared to the question of movement quality and control. Fine. So I will assess using this voluntary control pattern. Okay, this is I will do it for shoulder, elevation, flexion, abduction separately. I will do it for elbow separately and wrist separately, and know whether the patient is able to initiate, sustain, or terminate the movements. So you all know about coordination test. This was a presentation prepared for an undergraduation. I really don't want to waste your time by means of telling you how to do the test, because now this is not about how to do a test, it is about how to differentiate. So you are going to assess, next to motor system, you are going to assess the superficial touch, temperature and pressure sensation, deep sensation, and then cortical sensation, Whether you're going to do a cortical sensation or not is based upon your hypothesis. If your hypothesis says that this might be a lower motor neuron lesion, then you will not do a cortical sensation assessment. You got it. If you think that this patient is a Parkinson patient, you will not do a muscle power examination or a voluntary control examination. There you will do a examination of the movement time and the reaction time. So based upon what we are going to assess is dependent on our hypothesis, what we suspect. Next is the musculoskeletal examination, active range of motion and passive range of motion. This most of the people ignore in case of neurological examination. If I have a full and free passive range of motion, but my active range of motion is limited, then I will say the problem is with the muscle or the control mechanism of the muscle, where the active range of motion is diminished, but the passive movements is fine. But in case, if I find a patient with both active range of motion and passive range of motion limited, then I will blame only the joint structures. It might be a joint stiffness or a muscle stiffness. It is more of passive problem rather than a active problem. There are also instances where the active range of motion will be full and free, and the passive, not full and free, the passive range of motion will be more than the, sorry, active range of motion will be more than the passive range of motion. This can happen when the patient is having an apprehension to move. When the patient thinks that bending forwards will result in, if somebody do this movement, I will fall. If I do on my own, I am fine. Even in the shoulder elevation also, if the patient is having severe shoulder impingement syndrome, the patient will be reluctant when somebody is moving the upper limb. They will have a lot of apprehension. But when the patient is performing, he knows until when he can lift and where he will get pain. So he will be doing it. So very rare scenario, this when there is a pain or apprehension. So active range of motion and passive range of motion are very important. And then you have you have to give perturbations to all directions to see whether the patient is okay. So the static balance will his to integrate three sensory inputs. One is visual, another one is the proprioception, and the third one is his vestibular system. So these three inputs are very essential for him to do a proper balance. This is a dynamic balance where the patient asks him to turn to various sides without much disturbing the line of gravity and the center of gravity. Now the patient is giving him a much more difficult dynamic task to perform, where he is going to displace his line of gravity more compared to the previous two tasks, making him to reach within arm's length. And now she's going to make him reach beyond the arm's length. Can you see this? So this is advanced balanced dynamic balance testing. I mean to say advanced because this test is not advanced, but the efforts required from the patient is more advanced. So first you ask the patient to reach within arm's length, then you ask him to reach beyond arm's length. First ask him to reach forwards and then give him reaching towards the lateral side. Give him reaching with the normal hand and then hand. So all these are assessing the. So in belt, so that belt can help you in holding whenever the patient is falling. In Indian scenario, I normally use a towel to be tied in the patient's waist, and I just hold the towel so that I'm not giving a direct support to the patient, but at the same time when he is trying to fall, I will hold on to him very nicely. Test the balance in standing also, the same pattern how you have tested in sitting. Apart from that, ask him to stand on single leg and see whether he's able to do or not. All these things are balance testing. So there are some tests like functional reach test which you can perform to know how far the patient is reaching. It can be done in the frontal plane as well as the sagittal plane. There are a lot of variations. Okay, so these tests you can use to assess the balance. Symmetry of movement is very important. Postural strategies, hip strategy, ankle strategy, stepping strategy, all these things are very important. in localizing the lesion. Um, when you have a gait abnormality, you have to assess for gait parameters. You have objective assessment of the gait and subjective assessment. The objective assessment is always quantitative. When you are able to quantify the stride length, step length, the stride width, the toe out, okay, cadence, gait velocity, all these things are quantitative measures which can give you a numerological value. Okay, and the direction of propagation is also one. You can see that these things differ in individual stroke in individual neurological patients, the gait quality and quantity. You have fascinating type of gait in Parkinson's. You have ataxic gait in cerebellar lesion. You have circumdactory gait in case of stroke patient, their hip flexors will be weak, because of which they'll be using their abductors, and all these things will give you a clear idea. Finally, you have to go for a functional assessment using some tools, which is always better to give some numerological values, like case of a Barthel index or a functional independence measure. So after this, you are coming to a problem list. Okay, the problem list should be hierarchical using technical terms. I told you that the chief complaint should not have any technical terms, but the problem list should have technical terms. What problems you can treat should only be in the problem list. If the patient is having some ocular management, like the patient is having diplopia, if you don't have any treatment for that, as a physiotherapist, don't include that in your problem, because you are not going to give any solution. If the patient says that I am getting palpitations often, if I'm getting a sort of a cardiac symptoms, then don't prioritize in your problem list. Refer the patient to a concerned doctor. So what are all the problems you can give solution should be there in the problem list. After the problem list, devise the goal setting, divide it into short-term and long-term goal. This, according to me, is only having conventional value, but sometimes it helps people, but I don't prioritize them on a long-term and short-term goal in case of a neurological condition where you don't know the prognosis of the patient. It may be true in case of an orthopedic assessment where you can actually judge how a post-operative patient with ACL reconstruction or an osteoarthritis patient is going to progress. But in case of a neurological condition with a lot amount of uncertainty, I really question this people's attitude, people's action of doing short-term goal assessment and long-term goal assessment. And again, that is beyond the scope of this presentation. So this is normal neurological assessment, and next class is going to be more interesting, at least for my sake. I love the next session of the presentation, which is nothing but the differential diagnosis part. So we will give a quality 1 hour for that. Okay. So when you come back, we will go with even more in-depth analysis about the differential diagnosis. We will take 5 minutes break and we will assemble. Anybody is having sort of a fatigue or something like that, or you want to express certain thing, please let me know. Because this is 5 hours class, you have to remember one thing, how much of difficulty you have in listening to me. I have more than that difficulty in talking for continuously 5 to 6 hours. So it's the process of learning that is more important than the number of hours or number of participants. So just concentrate for 1 more hour, which will be very useful for you. Now 5 minutes break. We'll continue from where we have left. I think the upper motor neuron lesion and lower motor neuron lesion, you are very well comprehending. So now come to the spinal cord injuries, and there are 5 types of lesion in spinal cord injury. The anterior cord lesion, which is very common because we are designed to bend forward. So most of the time, any injury happens, it is anterior cord syndrome. Very, very rarely posterior cord syndrome, because extension is limited by the spinous process of your vertebra. So there is very less possibility of going for a hyperextension. Brown-Sequard syndrome is second most common to anterior cord syndrome, where it happens with the case of lateral flexion injuries, because you don't have any anatomical limiting structures for your lateral flexion. So you get Brown-Sequard syndrome also common. And central cord lesion are comparatively lesser, because you need an axial compression for this. It happens only when the patient falls from a height, directly lands on the buttock or on the feet. So these four things are the important spinal cord injury which manifest in upper motor neuron symptoms. And you also have a chordaequinal lesion, which is going to give you a lower motor neuron symptoms. One important thing I forgot to tell you in the classification of four important criteria for classifying the neurological condition into four different categories is that the spinal cord will can either be in the upper motor territory and lower motor territory also. It produces both upper motor neuron symptoms and lower motor neuron symptoms. Likewise, your motor neuron disease can also cause an upper motor neuron symptom and a lower motor neuron symptom, because in motor neuron disease, you will have a selective involvement of the motor neurons, irrespective of whether it is an upper motor neuron or a lower motor neuron. You will have a combination of these two. It can also produce pseudobulbar palsy, which is an upper motor neuron lesion, or it can cause a pure bulbar palsy, which is a lower motor neuron lesion. So the problem is with the motor neurons. Okay. So now coming to the anterior cord lesion. Normally in diagrams, how do they show in books is they will show like this, the anterior cord syndrome. The full anterior cord can be affected like this. But more often, it doesn't happen like that. It happens like this, where the peripheries are slightly spared and the central portions are more involved, and the anterior, it is more predominantly anterior. So now you can see what are all the structures that can be affected if it is an anterior cord syndrome, because the anterior portion is completely affected. One thing you should remember, if there is a complete cord lesion, then this question of anterior, posterior, central will not come. Only when there is an incomplete cord lesion, then these questions will arise. In case of a complete cord lesion, if it is happening at the level of C4, okay, below the level of C4, that is C5, C6, C7, all these areas will have complete motor loss onto both sides. Okay, they will have sensory loss, both superficial and deep sensation onto the both sides, and there will be complete cutoff, because the below C5 to remaining sacral segments all are cut off from the brain. So there will be no motor as well as sensory function below the level of C4. This is complete cord lesion. This is very easy to diagnose also. Okay, but in case of an incomplete cord lesion, your diagnosis and level of lesion finding is going to be very difficult. Okay, so how do we find the level of lesion? By means of assessing the motor and sensory functions. So when I say anterior cord syndrome, what is the anterior horn cells function? Anterior horn cells are completely motor. So both the motor cells on both the sides, anterior horn cells, are going to be affected. So they're going to be a motor deficits below the level of lesion. Got it? And you see that there will be any the upper limb is spared, because in this diagram they are showing a lesion at the level of T2 or T3. So in case there is a cervical involvement, C3 anterior cord syndrome, then the upper limb will also be affected. The only muscle that will be spared will be your trapezius. Okay, so this is how the manifestation is going to be. The lateral spinothalamic tract, which is here, can you see this, which is here, can also be affected in case of a anterior spinal cord injury, but it is based upon how much is the extent of the injury. In case if the anterior spinal cord injury is only up to this, there may not be much of spinothalamic involvement, but also you can see the anterior spinothalamic can be affected. So the spinothalamic tract is located laterally as well as anteriorly. So what happens? The anterior cord syndrome can affect the sensation, that is the superficial sensation of the carried by the lateral spinothalamic tract. Another thing what you have to see is cervical will be more affected compared to sacral, because cervical is more medial. You understand that or not? That is why we are seeing that very significantly. What happens to the deep sensation which are carried by the posterior column? That will be fine, no issues at all. So when you find bilateral motor deficits onto the lower bilateral motor deficits and bilateral sensory deficits, then you can very well confirm that the condition is an anterior cord lesion. This happens, you can confirm that with the mechanism of injury. You ask the patient how you had a fall, in which direction you fell, what momentum that has happened, how your body was postured. All these things you have to ask about the mechanism of injury, which will give an idea about whether it is an anterior cord syndrome or a central cord syndrome. Okay, so how the prognosis will be, the anterior cord prognosis will be poor. So this is why we should know what type of condition, where is a lesion, what type of spinal cord injury this is. Okay, so the prognosis is going to be very poor here because of the vasculature of the anterior aspect. Okay, very importantly, you should know one thing: the deep sensation are preserved. Okay, that should be underlined. So next is the posterior cord syndrome, where very rare condition, where the patient might have fallen from a height, and he might have fallen on a wall or a compound wall with his back hitting on the compound wall. So where that his body might have gone for a hyperextension, or somebody might have pulled him. This happens in case of people who go for the skating using a boat in water. I don't know what is the name of the sport, but they go for skiing holding on to the boat. So there they get an extension momentum. Suddenly when the vehicle pulls them, they get extensor injury. What happens? Where is the loss? The loss is mostly the vibration sensation and proprioception. You can see this is the vibration sensation and proprioception that is affected bilaterally. Your touch and temperature escapes, your motor escapes. So there is no pain, temperature, touch sensation lost, and there is no motor deficit also in these patients. Okay, posterior cord syndrome. Next is the central cord syndrome. Central cord syndrome happens when there is a hyperextension injury in the spinal cord, but in case of a lumbar spine, this is very rare, because the mechanism is also very rare. Like how very often people falling from heights will not fall on their feet. Their body will go horizontally, and they'll just like that fall on the flat back. Okay, so axial loading can cause this. In case of a central cord lesion, there is a HAT distribution, that is HAT. You can say hand, arm, and trunk. Head, arm, trunk distribution. So hand, arm, and the trunk distribution. So there is a HAT distribution on both the sides. That means the patient is having a central cord lesion. I also remember that because this looks like a hat. Hat in the sense it looks like this. So that also I remember in when I was doing my PG. So hand distribution is for central cord lesion. Why it is involving the hand? If you see in this arrangement, you have the cervical segments more. If there is a central cord lesion, it is going to involve the cervical spine. If it is going to be even more, it is going to involve the thoracic spine. Then here you are having motor loss. You have sensory loss, and also you have lumbar spine will be affected only when there is an extensive injury. Okay, so you see here loss of motor and sensory functions. Upper extremity affected more than lower extremity. Distal muscles affected more than the proximal muscles. Why distal muscles are affected? The cervical is more central, the thoracic is more lateral. So here is a position where your cervical spine is supplying the myotomes. So the recovery is average here. We saw anterior cord syndrome, it is poor, but in central cord it is average. Okay, so hat-like. Yeah, you can also get this case of a coup counter and counter coup whiplash injuries of the cervical spine can also result in the central cord syndrome. The patient can walk into a clinic, but the upper limb can be uh, highly hampered. The next one is the Brown-Sequard syndrome, where one half of the body vertebra can be affected. This can happen in case of a stab injury, or a gunshot injury, or a hyperlateral flexion injuries. Here what happens is one half of the body loses its, you can see one half of the spinal cord is being damaged. So what happens here? Differential diagnosis here becomes a little more trickier, because you know that the lateral spinothalamic tract carrying sensation crosses to the opposite side and ascends like this. So when there is a one-sided injury, for example, there is an injury here onto the left side. Okay, which side sensory loss, superficial sensory loss will be there? If I have a cut here, you will have an opposite side sensory loss. The sensory loss, superficial touch, temperature and pressure sensation will be lost on the opposite side. Whereas we also saw that the fibers of the posterior column do not cross opposite side. They remain on the same side up to the medulla. Only in the medulla they cross to opposite side. So when I have a lesion here, when I have a lesion on the one side, okay, on the right side, my same side perception kinesthesia. You understand? So this is the difference between the superficial and deep sensation. You can see ipsilateral loss of motor, vibration and proprioception. Contralateral loss of brain temperature and sensation. Why it is motor also ipsilateral? Because the pyramidal tract, when it comes from the brain, it crosses to the opposite side at the level of midbrain medulla itself, and then it descends on the opposite side. So when I have a lesion here on the right side of the patient, I will have only right side paralysis. Okay, so that is the difference. So Brown-Sequard syndrome has a very good prognosis. It has been proved that unilateral lesions of the body of the spinal cord have a better prognosis. To summarize, okay, this diagram I like a lot because it is visualizing the entire this is a transverse cord lesion, that is a complete cord lesion. You can see here in a complete cord lesion, all the three modalities, that is deep sensation, superficial sensation and motor, are lost below the level of lesion. Here just see this one. This is the Brown-Sequard syndrome. You can have one side of ipsilateral loss of deep sensation and the motor sensation, and contralateral side loss of uh, touch, temperature and pressure. In case of a central cord lesion, you will find a hat-like distribution. Your hand, arm and trunk will be affected, but here this is a small lesion, so it is only the hand and arm. But if it is a bigger lesion, it will affect this thing. Okay, so here in case of a central cord syndrome, larger lesion, you will have all the three modalities being affected. Okay, but only the sacral area will be spared. That is the genital area, sensation and the movement in the central area will be lacking, will be preserved, because we saw that the sacral segment is at the last, its outermost sacral segment, then the lumbar, then the thoracic, and the medial most is the cervical. So very rarely your sacral segments will be affected. When it comes to the posterior cord syndrome, Only the deep sensation will be affected. That is very easy. In anti-record syndrome, you will have below the level of lesion both motor and the superficial sensation being affected. If you observe all these things very clearly, you might ask me one question, very significant question. What is that? Sir, I have seen this picture. Here there is a small green color again, ipsilateral loss of pain and temperature. Can anyone see that? Why that is happening? So it is for an advanced understanding of yours that once the spinal nerve enters, for example, this is the L3 spinal nerve that is entering into the spinal cord. Once it enters into the posterior horn cells, 30% of the fibers crosses to the opposite side immediately. Next 30% crosses in L4. Next remaining 40% crosses in L3. So it takes almost 2 segments for the tract to cross to entirely opposite side. Only here it is completely having L3, L4, L5. After this one only, this L5 nerve segment is complete. You understand? Somebody has a doubt. 2 spinal levels of crossing. Exactly. Niraimati ma'am has clearly said that it takes at least 2 spinal segments for the nerve fibers to cross to the opposite side. So that is why when there is a problem in this level, okay, when there is a problem in this level of the spinal cord, you will also have ipsilateral loss of touch and temperature, a little bit, not much. Got it? So which is the most difficult assessment to do is the Brown-Sequard syndrome. But if you clearly assess the Brown-Sequard syndrome, if you have sensory loss, most superficial sensory loss on the opposite side, and on the same side, if you have only one patch of area, the patient do not have a proper sensation, you can very well tell that that is a level of lesion, because the damage has happened there. Most of the time you can detect whether tentatively you can say the lesion is between L3, L4 and L5, but we accurately say it is L3 and L4 because the borders dermatomes are being shared, and the dermatomes cannot give you a clear demarcation of the sensory loss. So you can tentatively come to a conclusion that this might be the lesion. If you have any doubt, otherwise I can move on to the next condition, differential diagnosis. I take it as positive. I'll move on. Now, the most different thing, the cardiac lesion, how it behaves. Any lesion that is below the L2 is called as cardiac lesion. Why this is, thank you, Shalini. Why this is called cardiac lesion below L2 is the spinal cord ends at the level of L2, and beyond that there is no spinal cord. There is only the spinal nerve that are going through. So now you may ask, what are these spinal nerves? The length of the vertebral column is larger than the length of the spinal cord. So the nerves have to travel some distance inside the spinal canal before they exit their respective nerve vertebral segments. For example, in this diagram, you see L5 is here. L5 spinal segment is here. Okay. So this is L5 spinal segment. The L5 spinal segment will give L5 spinal nerve that cannot exit here because the vertebra for L5 is here. Okay. So what it does, it has to travel from here all the way down through the spinal canal to exit through the L5 corresponding vertebra. Why this mismatch in the size? Because spinal cord is shorter than the vertebral column. So because of that, after the spinal cord has ended, you have a good amount of bunch of nerve fibers which are traveling inside the spinal cord, namely the L3, L4, L5, L6, and down to the coccygeal travel through this particular area. Any injury here, then that is called as cauda equina lesion. Most often this cauda equina lesion cannot be complete. Complete cord lesion is not possible because giving the anatomical location and strength of the vertebral column and the wide neural foramen, you not know neural canal, you most often don't find a complete cauda equina lesion. Very rarely it is. So what happens here, cauda equina lesion do not involve the injury to the spinal cord. It involves only the injury to the spinal nerves. So it results in a lower motor neuron lesion. Here, the paraplegia that is caused because of this will be areflexia, atonia. That is diminished reflex and diminished tone will be there. Okay, most often condition herniated disc causes the condition. That is why I tend to tell people, physiotherapists, that at a L5S1 spinal L5S1 disc bulge, don't tell people that your spinal cord is compressed because there is no spinal cord at L5S1. Please, can you mute yourself, participants? Thank you so much. So don't tell to people that your spinal cord is compressed because L5S1 or L4L5 your spinal cord is not there. You have to use this word thecal sac. So thecal sac compression. Thecal sac means a combination of the meningeal layer, the cerebrospinal fluid, and inside the thecal sac you have your spinal nerves. That is the one which is going to be compressed. That is why if you have a L5S1 compression, you will not have hyperreflexia, you will not have hypertonia. Whereas if you have a lesion at L7, T10 and T11, if there is any compression or any cord being compressed or edema is there or syringomyelia is there, you will see upper motor neuron sign. Okay, so all the sciatica, all the disc compression we see in the lumbar spine are all below L2. That's why we are going for a reflex assessment to know whether it is the spinal origin or not. Got it? So what are the main complications of cauda equina lesion? Problematic thing because your bladder centers for micturition are in S2 and S4. So here the lesion are above this. So the S2 and S4 are cut off from the brain. So the problem is they cannot go for voluntary voiding. Okay. Next is you will have bowel retention. You have anesthesia in the saddle region. That is, saddle region means the perirectal region and in the anal region and the genital region. And flaccidity will be there in the lower extremities. Loss of deep tendon reflexes and loss of rectal tone. So all these things are classical features of cauda equina syndrome. Is it lumbar radiculopathy or a cauda equina syndrome? How do you find is it a lumbar radiculopathy or a cauda equina syndrome? Anybody can answer this with all the understandings what you have got from the previous anatomy, physiology, everything? Okay, somebody's typing. Fine. So in case of a cauda equina syndrome, you will have urinary and bowel problems. In case of a lumbar radiculopathy, you won't have that. At single level radiculopathy, Sneha. What do you mean by single level radiculopathy? That is one particular dermatome will be affected. That is what you mean to say. But in case of a lumbar radiculopathy, if you have a multiple compression L2, L3, L3, L4, L4, L5, in case the patient is an aged person or he met with a trauma, you will have the problem. But lumbar radiculopathy, the primary problem the patient states, first thing will be pain. Pain and sensory in case of a lumbar radiculopathy, whereas in the cauda equina lesion, they will talk predominantly about Yeah. They predominantly talk about the bladder and bowel function and also about the flaccid paralysis of the lower limb. In lumbar radiculopathy, it is very rare. So when I say radiculopathy, what is the major difference between here anatomically? If you see, if I see this is the spinal cord, vertebral column, okay, and your spinal cord is here, and the intervertebral disc is here sitting in between the vertebra. If there is a compression of the intervertebral disc onto this particular lateral side, so from the spinal cord your nerve goes out, right? So if there is a compression here, then that is a lateral spinal cord lateral spinal nerve compression, which results only pain and paralysis and all symptoms, paresthesia on the right side alone. Left side will be fine. But in case if it is bilateral lateral compression, very rarely possible, both sides will be having problem, but the problem will be more sensory. Pain will be the predominant sign. Okay, apart from all these things, you also will have a problem which is happening in the central also. It can be a central compression also. How that will be central? If the disc comes more centrally and compresses the spinal cord as such, not spinal cord, the thecal sac as such, you will have bilateral symptoms. You will have bilaterally equal symptoms. Okay, so again, it is more predominantly pain and paresthesia, burning sensation or something like that, and loss of sensation is also possible. Lack of sensation or diminished sensation are also possible, but the motor symptoms will be last. The symptoms of motor will be coming up last only. Okay, so that is the differential diagnosis here. Now, if there is a this is a very important classification you should know when the patient is coming to you with cervical radiculopathy. Okay, most often the physiotherapist will be asked to go for a cervical traction, but you can know that the problem is not in the cervical spine. The problem in the peripheral nerve, maybe in the brachial plexus. The moment you go for traction, the pain goes for pain increases, aggravates, because the problem is in the brachial plexus, and you are pulling the brachial plexus from its origin by means of giving traction. The next day, a patient says, "Sir, after traction, the upper limb is completely numb and I'm feeling weakness also." So you have to think about the decision making then. Peripheral nerve lesion or a plexopathy from the foremost thing is by means of the weakness and the sensory pattern they produce. How will be the weakness in case if it is there? In case of peripheral nerve lesion, the weakness will be very severe. The patient will say, "Sir, I'm not able to hold any objects at all." In case of a nerve root impingement, the patient will say, "Sir, I'm having pain more than weakness." That is classically a radiculopathy, because motor fibers are placed in a spinal nerve root. If you see, this is the spinal nerve root, means the centralmost portion will be the motor fibers, the outermost portion will be your sensory fibers. So when there is a compression, first thing to be compressed is your sensory fibers rather than the motor fibers. So here in the nerve root, you will see that there is a complete pain and other symptoms as coming up first compared to the weakness. Here the severe, the after the spinal nerve root comes out and they divide into sensory and motor. So if there is a compression here, it will be predominantly motor and it will be severe. What happens to the muscle atrophy? Okay, if there is a severe weakness, you will have muscle atrophy, definitely. If there is a partial weakness, you will not have much of muscle atrophy. Sometimes it may be absent also. That's why we see patients coming with cervical spondylosis and severe radiculopathy with weakness of the limb. They don't have much of wasting because only partial motor loss will be there. Whereas if you see a patient with a carpal tunnel syndrome, you can very well see that there is a wasting of the thenar muscles. Got it? So next is the deep tendon reflex. This is why we do deep tendon reflexes in case of a orthopedic conditions, claiming to be neurological condition also, this radiculopathy. So when we do a deep reflexes, usually it is normal in case of a peripheral nerve lesion, because the sensory reflex integrating center is normal. but in case of cervical radiculopathy, it may be reduced or even absent. Okay. Next is muscle fasciculation. If there is a severe weakness, muscle fasciculation will be always present. In case if there is a less muscle weakness, the fasciculation may not be present. Fasciculation is nothing but flickering of the muscle fibers. Okay. Next is sensory loss. Sharp demarcated borders. So peripheral nerve has its own sensory distribution. For example, if the ulnar nerve is affected, ulnar nerve has a medial sensory distribution onto the olar as well as in the dorsal part. And the patient will say, sir, I have sensory loss in this particular area, sir. I don't have any other sensory loss. Whereas if the patient is, you can very well say that it is a radial nerve, ulnar nerve impingement. If the patient says, sir, I have all the medial borders, I'm having pain, loss of sensation or any other sensory symptoms, sharp pricking sensation or a sensation which is abnormal, you can say that this is C6 and C7 area. The patient will also say in the middle finger is I'm having problem. Only in the middle finger I'm having problem, mostly C7. So when there is a sharp demarcated border that is pertaining to the peripheral nerve, and if it is a broader area, okay, and if the patient may not be able to distinguish between the borders, then it is uh, a nerve root impingement at the cervical radiculopathy. Then paresthesias present in the nerve distribution. Again, in whichever the sensory distribution area of the peripheral nerve, you will have paresthesia here in case of the dermatomal level. How will be the pain? Radiates proximally or distally, because there is a compression here. If there is a compression in this lateral epicondyle region, the pain may travel upwards and lower. But in case if there is a compression here in the cervical radiculopathy, the patient always says, sir, the pain comes from up to down. That is why we ask the patient, where is the pain, from where it is radiating, to have a clear idea. So treatment differs for peripheral nerve lesion and for cervical radiculopathy. So as a physiotherapist, you should know how to differentiate between these two. Fine. Is that okay? Any doubts? Okay. Coming to the vertigo. It's a vertebral syndrome. So for assessing what is vertigo, you should know that what are all the, thank you so much. You should know what are all the vestibular disorders that are possible. Whenever a patient comes to you and say that I have vertigo, the first question you should ask whether you are having blurring of your vision or you are having you see objects rotating around you. Because when the patient is going for a blurring of vision, it might be most of the time it might be a hypoxia, or it might be hypoglycemia or hypertension, or many reasons are there, systemic reasons for this. But when the patient says, I feel everything is surrounding, and objects are moving around, that is when you suspect your vestibular system to be the problem. Because vestibular system gives you an information about the head orientation to the body, and the body and head orientation to the environment. Okay. So in case if there is a problem in the vestibular system, you feel instability, and your relationship with the head and body and the head and body with the environment will be having some issues. Fine. So there are two main types of vestibular disorders. One is a peripheral and another one is a central. So central vestibular disorder, our role is very less. Peripheral vestibular disorder, we have a good role to play. You have mechanical vestibular problem that is called as the benign paroxysmal positional vertigo, where there is a problem in the semicircular canals. Okay, so the semicircular canals give a abnormal sensation to the brain that your head is moving. In fact, when the head has stopped moving, it gives still information that your head is moving. That is called as benign paroxysmal positional vertigo. Mind you, this condition resolves 7 to 10 days on its own. No problem to, you need not give treatment also. But in the current scenario, what happens? Within that 7 days, the patient will be going for many professionals. They'll go to the ENT doctor, they'll go to the physiotherapist, they'll go to the medical professional, physician, diabetologist. Everywhere they go, take MRI, CT scan, and this agony of going to each and every doctor and taking a lot of diagnosis plays in their mind, and that giddiness will not leave their psychological thoughts, but biologically it has, they may get cured within 7 to 10 days, but psychologically they always feel that apprehension to move. They may feel like they are getting that giddiness always. That is a major problem in my experience I have seen. Next is decreased, this is mechanical. Second thing is physiological, where you have a decreased receptor input, that is your auditory system and your vestibular system are not functioning properly because of unilateral vestibular hypofunctioning. Sometimes it can also happen that both the sides can be affected, where the sensory receptors in your ears may not work properly in detecting the movement of the head. If it is unilateral, then the other side will be normally functioning, and there will be a mismatch between the information going from the right and left. Then also the brain will be confused. Or second, the bilateral vestibular hypofunctioning, where both ears send abnormal information to the brain. Again, then also the brain compares them and become confused, because the brain is also confirm the information by means of vision. When the ear says that you are moving, the eyes are going to say that you are not moving. Then there is a mismatch between the information given by the vestibular system and the visual system, and the patient may feel like they are falling. Got it. Next is the central vestibular disorder that may happen when there is any blood supply disturbance to the cerebellum. Okay, so anterior inferior cerebellar artery, posterior inferior cerebellar artery, and cerebellar vertebral artery are the one which are affected. Okay, how should I differentially diagnose? Nystagmus is a very important differential diagnosis here. Physiotherapists should train themselves in finding the nystagmus. The patient is coming to you when he is sitting like this, he doesn't have any nystagmus. That is called as lack of nystagmus. Okay, there is lack of spontaneous nystagmus. Okay, when you ask the patient to move the head this way and that way, up and down, sideways, then you see some nystagmus happening in the patient's eyes, then you can say that this condition is called as a BPPV. Remember, nystagmus is always BPPV, benign paroxysmal positional vertigo with semicircular canons. We are coming up with a vestibular rehabilitation program very shortly in My Rehab Academy. We have somewhere around 10 hours of teaching in vestibular rehabilitation alone, and we are going to guide you how to open up a vertigo clinic. If anybody is interested, you can enroll in that. So this is called as the BPPV. In case if the patient is having nystagmus, even when the patient is sitting simply, he is facing the therapist, then also if he is having nystagmus, then that is called as spontaneous nystagmus. When there is a spontaneous nystagmus, the physiotherapist should observe whether it is in bilateral direction on both sides or it is in unidirection. First of all, what is nystagmus? Nystagmus is a slow, involuntary movement of the eyeballs. It can be either onto right and left, or only onto the right, or up and down, or only onto the up, only onto the down, based upon the lesion. So that is called as upbeat nystagmus, downbeat nystagmus, right beat nystagmus, left beat nystagmus. All these things are the different names. So if the nystagmus is up and down, then it is pluridirectional. If it is only upbeat nystagmus, then it is unidirectional. So if it is a pluridirectional nystagmus, you can very well say it is a central vestibular disorder. If it is a unidirectional, then you have to do head impulse test. Head impulse test is done. Just look at me. You have to hold the patient's head with 30 degrees of flexion. You have to hold it like this. Imagine you are holding a patient's head in 30 degrees of flexion. His eyes should look into your nose in this manner. He has to look like this. Okay, then you move the head slowly onto either side, and suddenly you move the head onto one side with a more velocity. Then if the patient is not able to fix his eyes on your with your nose, and he misses the nose, then that is called as a positive sign. Here what happens is the patient is not able to fix eyes on the target when the head is moved fast. So that is a positive sign. In case if he is able to fix it even when you are moving fast, then that is negative. When the head impulse test is negative, then again it is a central. If the head impulse test is positive, then it is the peripheral vestibular disorder. What is peripheral vestibular disorder? In what way it differs from BPPV? BPPV is a mechanical problem where there is a problem in the semicircular canal. The unilateral and bilateral vestibular hypofunctioning or physiological receptors are not properly functioning. Hope you will not understand this very properly because it is a very extensive topic. You should know more about the anatomy of vestibular system. So I welcome you for the program which we will do later on. Now, wait, I'll come to this later. Okay, now peripheral neuropathy. Peripheral neuropathy is a very extensive field. Even neurologists find it very difficult to assess the peripheral neuropathy. They may not be able to come to a conclusion even after treating a patient for years together. So such is the complication of the peripheral neuropathy. But we will try to throw light on this. Okay, so you are taking a patient who you suspect the patient to have a peripheral neuropathy. After history and examination, okay, if you feel the patient is having history and examination compatible with neuropathy, if it is no, then go for some other evaluation. Okay, if you feel like the patient is having a neuropathy, then you have three things to determine between. It might be a mononeuropathy, it may be a mononeuropathy multiplex, that is more single nerve affected in both the lower limbs, or single nerve affected in upper limb and lower limb, only sensory nerves affected in the lower limb, like that, mononeuropathy multiplex. Or it can be a polyneuropathy, many nerves affected in the lower limb, many nerves affected in right and left limb, symmetrical, bilateral, sensory as well as motor. So these three things you have to decide. How you will come to a conclusion? You can do physically, but electrical diagnosis is the best way to do that. So once you do an electro diagnosis, you will know about all these things, and then later on you can come to a conclusion. Like if the electro diagnosis says, if there is the electro diagnosis will tell you whether you have a problem in the axon, or you have a problem in the myelin sheet, or the problem is physiological. Fine. So with electro diagnosis, we know to diagnose. We can read it from the electro diagnosis results. But how to do it physically? So when you are doing physically, you need to ask some question. What systems are involved first of all? Motor, sensory, autonomic, or a combination? First, you should answer this question. Or whether it is distal, only distal, or both. What is the distribution should be found out. Okay, whether it is present symmetrical. What is meant by focal? Focal means it is pertaining to only one area. So you have to ask these questions. So by asking these questions, if it is a symmetrical and it is involving the proximal and both proximal and distal weakness, it might be a hallmark of a condition called as GBS. Guillain-Barré syndrome can be the reason, where both proximal and distal motor system is affected, and it is symmetrical. It can be upper limb, both upper limbs and both lower limbs also. Then you can suspect a GBS, which is also a peripheral neuropathy. Okay, that is not the scenario. There is an asymmetric or multifocal pattern of weakness. In my upper limb, my deltoid is affected. In my lower limb, my gluteus muscles are affected, and my quadriceps are affected. Multifocal. Then we can say it is a motor neuron disease, amyotrophic lateral sclerosis. Based upon which motor nerve is affected, which area it is affected, it resides. So this is a two predominant things. How to differentiate between a motor neuron disease and a GBS. How to differentiate, because both of them looks almost same, but GBS is completely lower motor neuron symptoms. Amyotrophic lateral sclerosis will be predominantly combination of upper and lower motor neuron lesions. Sometimes they can also present as only a lower motor neuron lesion in the early stages. How you differentiate between these two? By saying that there is a symmetric involvement and there is a both proximal and distal muscles are equally involved, then it is GBS. If there is a symmetric involvement, but we are not able to differentiate the whether the proximal and distal are both involved, only proximal is involved, distal are performing well and good, then you can say it is a motor neuron disease. One more thing is GBS will always have a predisposing any infectious process. In the history taking, you have to make sure that, and there won't be much of sensory involvement in both these conditions. But nowadays there is a variant of GBS which is having a lot of sensory deficits also. In GBS you will have a glove and stocking syndrome, that is paresthesia in the hand and in the feet. That is called as the area where you wear your glove and stockings. There you can have a paresthesia. That is a classical symptom of Guillain-Barré syndrome. But this cannot be present in all the patients. Diagnosis between the early stages of motor neuron disease and the GBS becomes a hectic task for the physiotherapist. Next, what is the question we should ask? What is the nature of sensory involvement? Whether the sensory involvement is there or not? Whether it is a temperature, a burning sensation or a stabbing pain, what sensation he feels. If it is a temperature loss or a burning or stabbing sensation, then the C fibers are affected, small fibers. There is a condition called small fiber polyneuropathy. Only the sensory system will be affected, like in diabetes. Or if you find vibration or proprioception loss, larger fibers are also affected, complete sensory neuropathy. Is there evidence of upper motor neuron involvement? If the reflexes are more, tone is more, then what sort of sensory involvement is there? Okay, then if it is a small fiber, this is small fiber diabetic neuropathy we saw. Why diabetes do not involve the motor neuropathy? Because it cannot affect larger diameter fibers. It affects only the small diameter, and it sensory neuropathy because the microangio trauma that happens do not cure in case of diabetes, so it compounds to the problem. Next is asymmetric acute sensory and motor symptoms and signs, radiculopathies can be suggested. Okay, if there is a cervical cord compression, will have symmetric involvement, they will have sensory involvement, and sensory nerve distribution will be in the terms of the dermatomal pattern. So you can suspect a spinal level plexopathies or radiculopathies. We have seen that differential diagnosis previously. Next is, what is the temporal evolution? Temporal means time. What time it has taken for the disease to progress. Whether it is progressed in last 4 weeks, then that means it's acute. If it is progressing in 4 to 8 weeks, that is subacute. If it has progressed more than 8 weeks, then it is chronic. Okay, based upon the progression rate only we give acute demyelinating disease, means it has progressed within 4 weeks. It is not that the patient is in the early stages of the disease. Here you have to be very careful. Okay, or it might be monophasic, that is it might have come once and settled down properly, or remitting and relapsing. It might be anything, but the differential diagnosis can be, if it is acute or subacute, it can be GBS, vasculitis, or radiculopathies related to diabetes. In diabetes, when the HbA1c levels goes beyond 7.5, 8.5 maintains for 1 or 2 weeks, then also you can have neuropathies. But if it is more than 8 weeks or chronic, it is most neuropathies are very slow. Common peripheral neuropathies, any sensory motor neuropathy, proximal motor neuropathies, all these things are progressing very late. Only in GBS, vascular issues and other radiculopathies related to diabetes progress faster. You have to remember this. The remitting and relapsing causes can be present in chronic, inflammatory, demyelinating polyneuropathy, CIPD, chronic, because it is developing over a period of time. Okay, inflammatory, the inflammatory process can come and go in your body. So whenever the inflammatory process is on in your body, the symptoms come. When the inflammatory process subsides, the symptoms goes off. So chronic inflammatory demyelinating polyneuropathy. Okay, so next question you have to ask is the symmetric sensory loss and the distal areflexia with upper motor neuron finding. So here you have symmetric sensory loss, and the motor system is also upper motor neuron findings are also present. Then you can suspect something in the systemic problem, that is your vitamin D12, B12 or vitamin E deficiency or copper deficiency. I had a patient in my clinic a few years before. He came with weakness of his upper limb. His doctor told him that he is having a cervical radiculopathy, and he was having mild pain. So the doctor suggested him to go for a cervical traction. When I spoke to the doctor, he said, in case of a severe cervical compression, the pain may not be a big issue, only the motor symptoms may be a big issue. Then I went with traction, and we normally gave some exercises, but the patient did not recover. I saw him after 2 weeks. He was having complete weakness of the shoulder. He was having complete slight weakness starting up with his lower limb also. Patient did not have any infection. Patient's inflammatory titers were normal in his blood, and he did not have any autoimmune sort of conditions going on, because his inflammatory titers were absolutely fine. He was not having any problem. So the doctor was completely insisting that he is having a big lesion in the cervical spine, compression of the cervical spine by the vertebra. So please go for traction continue. So I had my options to assess his reflex, and all his reflexes were hyperreflexia. And I told the doctor that he is having hyperreflexia and hypertonia, and he is starting to develop some sort of a spasticity pattern. Then that is when the doctor took him for further analysis and found out that his body was having more amount of lead. The metal lead was inhaled continuously, which was affecting his brain. So the exposure to lead was the major issue for the patient. He was working in a factory which was using lead as the byproduct, and he was not aware of that. So in his blood, when the lead was detected, the doctor started him to treat in a different way. And you won't believe me, within a matter of 6 months, the patient became normal, and he somehow escaped that problem. So differential diagnosis plays a very important role when you assess neurological patients. Okay, so in case of a symmetrical weakness without sensory loss, only symmetric weakness is there, no sensory losses are there, no proximal or weakness, distal weakness are there. Sorry, if there is a proximal and distal weakness, both of them are there, you can also suspect spinal muscular atrophy. We saw that we can also suspect Guillain-Barré syndrome. Okay, if only the distal muscles are weak, proximal muscles are fine, only the distal muscles are weak, it can be a hereditary motor neuropathy. Okay, so there are a lot of motor neuropathies which are existing, which can confuse you so badly. So it is up to you to decide on that. Okay. What are the symptoms of autonomic neuropathy? If you want to know, their patient will have orthostatic hypotension, heat intolerance will be there, and also bladder and bowel function will be affected, and sexual dysfunction will be there. Patient will say that I am not able to go to the sun at all. So that is one classical symptom. Okay, with this I will finish. For lower motor neuron lesion, to localize where is the problem, whether it is in the anterior horn cells or the peripheral nerve or in the neuromuscular junction or in the muscle as such. one important question you have to ask is, how is the distribution? If the distribution is asymmetrical, okay, and it is asymmetrical in the face as well as in the lower limb, in the limbs, then definitely the problem can be anterior horn cell. If it is symmetric and mostly involving the distal, it can be a peripheral nerve lesion. If it is extraocular, or that means the eyes, most of them, the patients with neuromuscular junction disorder have ptosis, and they will have extraocular involvement, because these eye muscles need lot of neuromuscular junction, and they have lot of movement properties. The velocity of movement is dependent on that. So when there is a neuromuscular junction disorder, the first thing to be affected is your extraocular muscles and your bulbar muscles. Here, the involvement of the limb will be more proximal muscles. Large group of muscles will be affected. Then you can say it is a neuromuscular junction disorder. If the muscle is involved, it will be symmetric, proximal, or distal. There won't be a specific pattern. In case of a Duchenne's muscular dystrophy, you will find that it will be symmetrical. First proximal will be affected, later on the distal can also be affected. So this rule, if you follow, then you can differentially diagnose these 4 categories. Got it? And last but not least, your urinary, that is your bladder and bowel distribution distinction. For bladder and bowel, if you want to distinguish between a spastic bladder and a flaccid bladder, you should know the physiology of the bladder. The mixturation is the process of uh, releasing urine, that is called mixturation. You know that. So where are the centers for that? The first center for the mixturation is there in the prefrontal cortex. The prefrontal cortex is responsible for telling you whether this location is good for you to go for a mixturation, this ambience is good or not. All the social things that are associated with the mixturation are given by the prefrontal cortex. That is why we see kids do not know the social context. Their brain has not developed in the early days, so they keep passing urine everywhere. That is why people who have upper motor neuron lesion, who have stroke, they don't know whether they are passing urine or not. They just like that pass, they don't know where they are passing. So that's why we give catheter. So the first center is there, the prefrontal cortex. There is one more center for them in the pontine region, which is called as the pontine mixturation center, which is actually the command center. Day-to-day basis, a person goes to the toilet. Okay, the moment he undresses himself, he goes to the pons. The pons says that, yeah, I'm ready for the person is ready for, and it discharges information to the pontine center, and he urinates. So difference between the cortical center and the pontine center is, the cortical center will tell you whether this is the correct time, place, social area to go or not. It cannot make a person to pass urine. But the pontine mixturation center's work is to release, stop, release, stop. So that is the role of the pontine. So the pontine sends information to the sympathetic and parasympathetic nerve fibers. Where is the sympathetic center? T10 to L2. Ignore that, not an issue at all. But the parasympathetic center are the one which releases the urine. These are the one which releases the urine. So they are located in S2 to S4. Okay, this is the minimum knowledge. And you should know what is the role of sympathetic and parasympathetic in the release of urine. When there is a sympathetic stimulation, your detrusor muscles relaxes. That means your urinary bag becomes larger. It relaxes. Okay, your neck of the bladder, which consists the splinters, will contract. That means what? When you are blowing air through a balloon, okay, how do you hold the neck tight and the balloon should be relaxed? You won't hold the balloon tight. So this is the sympathetic stimulation. Blowing balloon into the urinary bladder is the sympathetic stimulation. You're holding the neck tight. It increases the volume. But when you want to pass urine, what system is activated? Your parasympathetic nervous system is activated. What it does? It squeezes the detrusor muscles and relaxes the neck of the bladder so that the bladder releases the urine. Got it? That is a function of these two. What happens in a lesion? In case of a lesion, upper motor neuron lesion causes spastic bladder and lower motor neuron lesion causes flaccid bladder. Okay, well and good. Spastic means upper motor, flaccid means lower motor. We all know that. But what about the tone? There is a hypertonia, hypotonia. That is also fine. Detrusor muscles, involuntary intermittent contraction of the detrusor muscles. So whenever there is a sensory input to the body, somebody is pinching you, the patient will pass urine. If the patient is getting an injection, he will pass urine. When the patient is laughing, he will pass urine. When there is any sensory inputs to the patient will uncontrollably lose his urine. That is called as spastic bladder. Here, in case of a flaccid bladder, you see that sort of an activity. There will be more amount of residual urine. Okay, when the patient is passing urine, the patient will not have control on the urine. At the same time, squeeze the detrusor muscle, empty the entire bladder. He will have more residual urine. Okay, when flaccid spastic bladder will damage or the cerebrovascular accident. In case if the brain is affected, brain may be affected in the cortex, it may be affected in the brainstem or wherever it is, then it causes a spastic upper motor neuron type of lesion. If the spinal cord is affected above T12, that is the spinal cord is there, this is the level of T12, okay, and if the any injury above this, that is called as above T12, so you will have a spastic bladder because your sympathetic outflow chain is here and S2 S4 is coming below that, so entire system is not connected with the upper motor neuron, so then it is called as a spastic. In case if the lesion is below this T12 or at the level of S2 and S4, the anterior horn cells of the S2 and S4 are affected, or there may be a problem in the nerve that carries information to the detrusor muscles, then it is a lower motor neuron lesion. So what is the basic difference between these two bladder, how they behave? One will be a flaccid bladder. You need to squeeze your bladder every time to pass urine, whereas the other bladder will be very reflexive bladder, where you don't know when the urine will escape from the patient's urinals. Any sensory input can activate the urine discharge. Okay, so we are coming to the conclusion of this program. I think it's a very extensive session. Also, and you can also ask any doubts if you have right now. I also welcome you all for the program on the approaches 5 to 8 today. Yeah. Any doubts, Madhavji? Participants, you can ask me any doubts if you have, or you can give your feedback, because that will help me in improvising in the future presentation. Saurabhji?
Yes, sir.
I think no doubts from the participants.
Yeah, from participant side, no doubt. So looks like okay. Let them go with the lecture. I think then it will be better for them to ask the doubt.
Yeah, sure.
Yeah, and sir, from my side, I can tell my review that it was like a. I can't say that it was excellent. It was a class apart. I mean, I never had such a wonderful lecture, maybe past 12 years, ever since I left my undergraduation in the college. So, and then, yeah, I think I actually got my neuro teacher back today. It is a kind of revision right from the 1 to Z, not A to Z. It's right from the revision of 1 to Z. It was a wonderful delivery and content, sir. Really good.
Thank you.
Yeah, I missed some of the parts in the spinal cord that anyway I'll go through, and I'll ask you some of the doubts if I'm having. I had some personal work, so I could not attend. So
No issues.
some
No
of the
issues.
spinal cord, yeah, spinal cord issue I had. So anyway, I'll ask you once I go through that, and then yeah,
As you should. As you
and
should.
yeah, and then participants, I want to tell that please ask your doubts. Sir is ready to take your question. Another thing that you will get that feedback link just after immediately finishing the class. So you can just fill up the link. The moment you submit, within few minutes, your certificates also will be ready. So that is how it has been linked. So I think CEO sir is there. Sir, CEO sir. Hello.
Hello. I
Yeah.
think
See.
he is muted. I think he is.
Okay. I think he must be busy in some work. Okay. So fine, then that's what I just wanted to inform them that technology has gone so high that they have to just submit the feedback link and other things will be done, and seeing their this one, the certificates will be ready. So not a problem,
Yeah.
and
Thank you.
they can yeah, yes sir,
Thank you, Saurabh. All the
yeah, and
participants. Yeah.
yeah, and then we are waiting for more and more informative classes from you in Neuro.
Yeah. Always. Always.
Yeah. Yeah, and this is a purely a content of classroom. I think we need a 2 days to continue because the kind of examination we have to do with the patient,
Yeah.
it is really a time-taking stuff.
We
Yeah.
can have
Yes,
offline.
sir. Sure, sir.
Have a workshop, physical workshop, offline.
Yes, yes, sir. Yes, sir. That's what I was. Yeah. Okay, sir. Then, with your permission, can we wind up then?
Yes, sir. Yes. Thank you. I
Yeah.
should thank the audience.
Yeah, thank you so
Special
much, sir.
thanks. Thank you,
Thank you.
sir. My special thanks to Dr. Kritika ma'am, who is attending the
Yes.
second program of mine, and she herself is a very strong person from the same school of myself. We all are from school of Ramachandra College of Physiotherapy. So her presence here has increased my responsibility also. So thank you, ma'am, for attending.
Thank you, ma'am.
Thank you,
Thank you
sir.
so much.
Thank you, sir. Good to hear your talk after a long time. Thank you, sir. Thank you so much. And thank you, organizing committee also.
Thank you, ma'am. Thank you so much. And I also thank all the participants who have communicated and expressed. Please go through the video, and if you have any, thank you. Thank you.